Yeah. Right. Good evening, everybody, and welcome to the Health and Adult Social Care Overview and Scrutiny Committee. We have apologies from Martin Cheeseman from Health Watch. Can I sign the record of the meeting held on the 1st of December last year? Great, thank you. I have no urgent business to announce. Are there any disclosable, pecuniary or other significant interests to be declared? No, thank you. Which takes us on to agenda item 5, and we have David Brake here, the portfolio holder for adult services. So, David, you did mention you had a very, very brief introduction you'd like to give. If I can hold you to the brief, and over to you.
Thank you very much, David, and a very good evening to you all. And if I haven't said it to anybody that's missed out, a very happy new year to you all. Thank you. Very short introduction, and really to say thank you for this opportunity to share with you some of the successes and the constraints that have been overcome in 2021 to 2022, as well as, of course, the challenges. We have had a difficult and challenging year in 2021 too, with changes across the sector in response to the coronavirus pandemic. Both public health and adult social care were and continue to be busier than ever supporting Medway's residents and ensuring that service users remain at the heart of everything we do.
Sorry.
Yeah, sure.
Thank you.
Okay. And finally, I would say we will continue to look at ways in which we can support our residents to remain in their own homes, to live amongst their friends and family for as long as is possible. And I'll leave that my introduction at that. And I'm more than happy to take questions from members. Hopefully, you've all had the opportunity of reading the reports that have been given. Thank you.
Yep, thank you. It was a very good report. Dan or Councillor MacDonald.
Thank you, Chair, and thank you, Councillor Brake. Councillor Brake, I've just got a few questions. I can stop after each one, or you can just note them down and come back to me. It's up to you what you want to do. The first one is around the increase in safeguarding concerns. Now, I know sometimes an increase in reporting is a good thing because it means maybe the message is getting out there. Are you concerned at all about the increase with the safeguarding concerns? For example, 2,053 concerns in 2021-22. The second one, did you want to answer, Councillor Brake, first? Shall I give you a chance to answer each one? It'd be easier. Go on.
Yeah, that's probably
Chair? Is that all right, Chair,
way.
rather than going through each question?
Right. While there's an interruption, Joe, Councillor Price hasn't got a microphone.
I think we're sharing.
Is that the idea?
I think we're sharing.
Yeah.
Oh.
Okay.
Okay, thank you.
Oh, no.
Sorry, Councillor Brake.
No, that's all right. No, it's good that you do that, really.
Over to you.
No, thank you for the question. It's interesting because this particular point came up this morning when we were talking about the Medway champions. And the fact is that we are, in some regard, the victims of our own success. And I say victims in as much as that, it's not all that long ago that if there was a safeguarding issue, then we never really heard about it until it was too late. But now I think the word is out there that there is no fear to be had in raising an issue. If somebody in the community does have a concern over an individual or a family or whatever may be happening, we've reached the stage where people will pick up the phone and they will get in touch and they will speak to somebody within Medway Council or one of our partners. So I think that it's good that we've got that rapport with the community. It does give extra work for the team, as you're probably aware, because it all has to be investigated, but it's all worthwhile. And I'd much sooner have that than have a horror story on on our doorstep. Hope that
Right.
answers.
Okay, thank you, Councillor Bray. And the second one is, are you concerned with the state of the NHS at the moment and how the crisis may impact your discharge pathway plans? Because obviously in the report it's all about the discharge pathway and how we're trying to get people out at the hospital, etc. Do you think that the crisis in the hospital and the NHS as a whole at the moment will impact on that and Medway's plans for the pathways?
Well, again, I think it's true to say that Medway Council has gone through the stage of the work that we did on discharge. In fact, was actually put on a pedestal, but just before the pandemic, as the best practice to be followed right across the whole of the country. And the number of inquiries that we had from various other authorities saying, how do you do it? Please explain what's so different. Well, the fact is that when with the system that is in place in normal circumstances, although in fairness, please define normal, but basically the moment somebody went into hospital, that's the moment that the time clock started, and our team would be working together with MFT and our partners to make sure that when somebody was ready to be discharged, all the boxes would be ticked. We knew exactly where we were going, and if that individual, for example, would be going home, or whether they would be required to go into a care home for a period of time, all that sort of thing was mapped out. But obviously with the pandemic, it went wild, and as you're aware, NHS in their wisdom decided that we had to be supportive of getting people out of hospital beds, which we were obviously pleased to do, but everybody has to be dealt with in a proper manner. In other words, an assessment has to be done. You just can't say, right, that person's ready to go, out they go. It's got to be done, it's got to be managed such that we give the right approach to individuals. And of course, in Medway and our own team, we will be doing our utmost to support the hospital, but it will never, ever be against the safety of any one of those patients who are in hospital. I hope that helps.
Thank you, Councillor Bray. So regarding the crisis in the NHS at the moment, we're from as far as you're concerned and Medway Council are concerned, the directorate is that the discharge pathway will carry on as it should now. It's not impacting the discharge pathway in its current form, even though, for example, the hospital's gone through a critical, I'll touch on that with MFT anyway, but a critical incident, etc. It's not impacting our discharge pathway plans.
Not as far as I'm aware, but I will take advice and guidance from Jackie, who is here this evening. And of course, we've also got Jane Black, who is behind me, and I'm sure that at the appropriate time, when it comes to ask the questions of MFT, hopefully our answers will be the same. Jackie, is there anything that you'd like to comment on this one, please?
Sorry, yeah, if I said it wasn't challenging, I think we would be lying at the moment. You know, there are some significant challenges, and as David has said, Councillor Bray has said, but working together, I think Jane would agree that we work closely together to do our utmost to enable people to be discharged from hospital at pace, and as David says, safely. The reason I say we work together is because we have calls twice a day, 3 times a day actually, to look at how we, you know, where patients can be discharged to and the right place for them to be discharged. So, you know, if I said it was easy, I would be absolutely lying, but, you know, at the moment, I don't think we could be working any closer or harder than we are.
Chair, there's only a couple of quick ones now, so that well, hopefully quick ones. I'll ask you the 2 really quick ones, David. If you keep them in your, you can make a little note of that. Then I'll ask you my main one. The one which we may not know the answer to at the moment is: do we know how many care home beds the government will fund in Medway yet? Do we know that yet? Because they would say that I presume that's not out yet, the information's out on that. The other one is about the Dementia Alliance, Councillor Brake. You know, you're a champion for the Dementia Alliance. We've done a lot of work on that as a committee and as we've done a focus group, etc. Are we giving enough support to the Dementia Alliance? Are we giving enough support for one of the most increasing illnesses with dementia increasing, especially throughout Medway, and our population is going to be growing, the age of our population, especially over the 80s, over 80 years old, etc. Are we doing enough? And then the final question, which I think you will enjoy, is what is your view on the establishment of the integrated care system on board? And do you think Medway will be treated fairly and get its fair share over the next year? And that's my questions, Chair.
There was no easy ones amongst that little. No, thank you for those points, Dan. The care home funding, that is obviously all we know at the moment is what has been said by central government, and that is to give support to the hospitals in the discharge of those into the community. But this really leads on from the last question that was asked, and that is to say that Medway Council and the adult services are very much a part of the partnership that goes with the hospital and others to make sure that we do what is right and the best for a patient. Obviously, the last thing we want to do is to get involved in the revolving door syndrome, where somebody comes out of hospital, gets delivered home, only to be back in hospital within a very short space of time. So all of these issues, and I'm just using that one as an example, all of these issues and areas have to be looked at to make sure that we do the very best for the patient. Patient first is always the watch phrase. With regards to Dementia Alliance, I share your views and share your concerns because this is something that has been going on for some considerable time. And I find it interesting that ever since I've been a councillor and coming through the system, that those with dementia, the number seems to be on the increase. But again, I think going back to the very first point, and that is that it's about the safety of individuals, and probably we know a lot more about dementia and associated illnesses and concerns, that this is very much to the fore. And the work that we do and continue to do right across the community, I don't think that'll ever stop. And every so often, you know, we have to go back and revisit, you know, perhaps it's time that we looked at Arriva buses again, perhaps it's time that we looked at the railway network and British Rail and other such organisations to make sure and keep pushing that message out to people that are involved and come into daily contact with people, that they really do understand what dementia is all about. And the final one, the integrated care. Well, it's strange you should ask that, because I was having a 2-minute aside with Jackie just before we started the meeting, and there is additional work that we are doing on that one to make sure that we're well and truly covered. Jackie, I don't know, would you like to add any more to that?
No, nothing specific. I mean, Leanne is on the board. I don't know what the title of your role is, but she's on the ICB board. We attend as many meetings that we possibly can, and are very vocal about the fact that Medway needs to be part of that and recognised. So no specific concerns at the moment.
I mean, I think, sorry, Chair, the question was, do we... I know we make sure we get our point, and I know the ref centres definitely make sure. I was thinking, are you confident that we will get our fair share? Because obviously we've had some issues over the last few years where we've lost services to elsewhere. Are we confident that we will get our fair share here in Medway? I think that's the question I'm asking.
That Medway is treated fairly. I'm absolutely confident Medway is recognised as a a legitimate and well-respected partner. Whether we get a resource that we like is a different question, but in terms of the process, in terms of working relationships, how the system's operating, yes, I am very confident.
Thank you, Dan.
Thank you. Councillor Murray.
To ask you about a couple of things that are not in the report. You haven't put anything in there about furniture management or about recruitment. And I wonder if you're across the extent to which we're still having to use social workers from agencies, and whether you think there's more that we can do to help our partners in care services like domiciliary care recruit more people, because we know that they're losing them. That's my first question. Second question is that the support to live at home service is being recommissioned this year. And I wonder if there are any plans in place in partnership, perhaps with the Hospital Trust, to develop some of these step-down facilities that are being developed around the country. You yourself mentioned the revolving door issue of people being discharged from hospital as quickly as possible and then returning too quickly. And it seems to me that there's a gap in Medway, in spite of our good re-ablement service, for facilities which actually allow people to recover in a kind of supervised and supported environment before they actually go home. So I wonder if you think that there should be any plans in place for something like that, or whether you know if there are. Finally, I wanted to say I really think the local account is good, and I think the staff deserve all our praise and thanks. Actually, they're a very, in my view anyway, cooperative team who are outward looking and prepared to work with co-workers and allied health professionals to do the best that they can. I never see anything about the things that they do on the council's social media. I never see anything referring to the local account or lifts from this good and easy to understand document about what the council's got to offer in that respect, so that people can look forward to being looked after in later life, that they can plan for it, that they know if they've got a disabled member in their family or somebody has suddenly become ill, that the council is actually there for them. I don't think the profile of adult social care and all of the good things that the staff do is high enough, and I wonder what you have done to raise their profile using the council's resources.
Thank you. Nice list of questions there, thank you. First of all, I'll go back to the first question you raised, or the first point that you raised, and that is the recruitment. And there's no doubt about it that the pandemic certainly changed the lives of so many organisations and individuals within the organisation, and Medway is no different. Certainly we've had people, our own staff, that have left, wanted to move on. Certainly we found that in the care homes there's been an increase in the turnover of staff. But my own personal view is that, having met so many of these individuals, that I think that, and again, this is a personal view that comes from me, and I believe that the people that have worked in the care centre, I think they're very committed people. They're people who have taken on the role more as a what's the word I'm looking for? It's more. It's what they want to do. I can't think of the word, but thank you very much. Yeah, it's a vocation, and I honestly do believe, and we are beginning to see this, but very, very small numbers, that we're finding that some of those people are beginning to come back into the programme, simply because that's what they enjoy. They enjoy working with the people. They like, it's that way of helping, being part of the community and helping people out. And I do believe that a lot of the people that have said enough's enough and have walked away from the care programme or the care service, I think a lot of those will eventually come back, but I don't know when. But in the meantime, you're quite right, we've got to do our part to improve on the profile, to let people know this is the job to be in, this is the opportunity, and really make it a career pathway for people rather than somebody who's just going to come along, join as a care worker, get assigned to work with a company, and they go out doing their rounds. They need to be looked after, they need to be respected, we need to make sure that they have, just an example, they have ample time to be able to travel between one visit to a home to another. All too often we've seen individuals that are having to rush around and they're not giving the quality service. And it is important that we do give a good quality service and that we don't overstretch those people who do work for us. We've got to make them feel worthwhile and that they are full members of the team that we operate. So yes, we do need to raise the profile, and we do need to do up the ante on the recruitment side. And you're quite right, for us to continue using agency staff is not the way forward. Apart from anything else, it's blooming expensive. You know, I think it's at least twice the sum that is the average wage that is having to be paid to go for agency workers. So we want to come away from that. People living at home, and again, I think I've just touched on that in some respects with regards the care workers and the regular visits that carers make. There is, in fact, partnership. We, together with the hospital and others, are all in this as partners, and collectively we all have to work together, and we do work together to make sure that we give the best possible service we can with the people that we have around us. And if there are ways to improve on that programme, this is something that the team will in fact be doing together as partners to look for the best way forward. And if it means that looking a step down and making sure that we do go away from the revolving door syndrome, that is important. You mentioned about the opportunity of recovering in facilities before perhaps going directly to their homes. In fact, in the stroke services within Medway, today there is a similar sort of arrangement where before, if somebody's had a minor stroke, before they're just packed off home, they do in fact go into residential care facilities where they are brought up to the appropriate level that they can go home and can either look after themselves, be looked after by family members, or can be assisted by care workers. So that's already in place. So it's an opportunity for us to learn from what we do well in that area and look to push it across into general care areas. The local account is good, you mentioned, and I fully support that. I think we have an absolutely wonderful people as not only that within Medway Council, but within MFT, we have some wonderful, truly wonderful people. And the people that I've met in all of those areas, they're always so positive. They always want to see the best. They always want to do the very best for the people in Medway. And it's something that we do praise them. And it is important that we make sure that these people realise that we recognise their worth. I hope that covers the questions that you've answered, you've asked. But
Thank
if
you.
if I've missed anything, do come back, please.
Thank you, Chairman. I'm just going to come back with a couple of observations. I appreciate your personal perspective on some of these things. I did ask a specific question. You know, you've said generally it's all a very good thing to do and everyone's great. But, you know, one of the reasons that there's an attrition of workers in care, and I think particularly in domiciliary care, is pay. The average wage for care workers is £9.50. And in Aldi and Lidl, you can earn £11.50 and not necessarily have to work the kind of unsocial hours or travel between sites and not get paid for travelling. And in some cases, in some domiciliary care agencies, not get sick pay either. So I'm afraid that there is a real need to put our weight behind a complete review of the care industry. You said it needs professionalising, and absolutely it does. You said it needs to be made attractive, absolutely it does. But I'm afraid for all and ever, we're paying poverty wages to the people who look after the most vulnerable people in our community. I don't think many of the people that you mentioned are going to come rushing back, however much of a vocation they had, because they've got to live. So that's one aspect of what I wanted to say. I spoke specifically about recommissioning the support to live at home service. And again, you know, you've agreed it's a good thing to do. And yes, we certainly have the quite pressured service at Amherst Court, looking after stroke victims and other people with more serious conditions of all ages. But the newer facilities that are being developed in some hospitals around the country, jointly sometimes with local authorities, are really for people with longer-term medical conditions in later life who need reablement. And so hopefully maybe Jane will be able to, you know, shed some light on that when she speaks. And if there's anything that we can jointly do, I think that would be a good thing. You didn't answer my question as to why I never see much on the council's social media about the good services that we have in adult social care. And one of the reasons I've asked that is not just because actually we should shout about it. I explained to you that I want residents to have an easy way to find out about it, but also, of course, if we're showing to as wide an audience as possible that we're as proud as you quite rightly say we are of the things that go on, then I think that's one of the things that would make people want to work for Medway. If we're confident enough to show what we've got with the resources we have. So I wonder, why don't we have more of that? Why am I always hearing about what's going on at Rochester Castle on the council's website? And I never hear, and have looked back, by the way, I never hear about what's going on in adult social care.
Thank you. It's a very valid point that you've made, Councillor Murray. And yes, I agree that instead of people shouting about Medway or Rochester Castle, it's time that the adult services went onto the battlements of Rochester Castle and started shouting about what we're doing in adult services. You're absolutely right. What I tend to do, in fact, with our staff, and I don't mind saying this, that there are many occasions that people come to my attention that within our own staff that have gone above and beyond the call of duty. And I always make a point of dropping those people a line and just to let them know that I know what they've been up to and what they've done, and saying thank you very much for what you've done. Trying my best to make them feel special. But that's within Medway Council. That's within what we do in our daily work. But I think the report that you have in front of you tonight, when I read through it and picked all the bones out of it, and one or two things were modified slightly to suit the circumstances, it really did make me feel extremely proud of the work that is being undertaken by adult social services and our social care. this report does, in fact, is probably the lead up to standing on the battlements of Rochester Castle and shouting as to the things that we do right across the Medway. But a valid point, thank you, and we'll make sure that we're going to be shouting louder.
Thank you, David. Jackie would like to come in, I believe. Could you say your job title for the greater audience? Sorry, your sign has fallen over, so no one will be able to see it. Yes.
Thank you, Councillor Waddy. I'm Jackie Brown. I'm the Assistant Director for Adult Social Care here in Medway. I just wanted to quickly touch on something that Councillor Brake won't have known about because there's only been a discussion today and I've not had the chance to update him yet. So part of the Adult Social Care Discharge Fund, we're actually looking at how we can use some of that money for step-down beds. Now, we don't know what that will look like long-term, but there's a building identified. Obviously, can't explain what that is at the moment, but it would be a 15-bed facility. And from that, we will then be looking at longer term about how do we move forward, whether that can be expanded. I'm also aware of some additional beds coming up in September of this year now, that we will be looking with partnership commissioning to see whether that we can turn those into step-down beds as well. And I just wanted to touch on the home care rate. So we received confirmation from the UK Home Care Association yesterday that the suggested hourly rate to be paid to a home care provider should be £25.45p, something along those lines. There aren't any councils, apart from probably Oxfordshire at the moment, that pay anywhere near that rate. But the fair cost of care exercise, although it's been paused, we are still being asked by the department to work towards that fair cost of care. Now, we received notification about that just before Christmas, but the webinars that have given us the detail only took place in the last day or so. For us to reach that limit, and the same with other local authorities, you're looking at about a 60% increase, which we can't do. So from a lobbying point of view, that's now something that I'll be going through with Councillor Brake. We do with ADAS. We have a meeting on Friday, so I just wanted to touch on that. Thank you. Okay.
Thank you. Now I have 5 more councillors who wish to ask questions, so if I can ask you to keep them brief, and even more unlikely, Councillor Brake, if you could give brief responses, please. Councillor Lammas.
Thank you, Chair, and thank you, Councillor Brake. Just wanted to thank Brake, first of all. I had a constituent contact me for Christmas with an issue with a care payment. I contacted Councillor Brake, he replied the same day, and the issue was resolved the next day. So on behalf of them, and I've already thanked you personally, but on the record, I just wanted to thank you for that. I think that's very good. My question, Chair, is about adult mental health and disability services. The report highlights something that the committee have read a few times now, which is that people with moderate and severe learning disabilities who are in receipt of services below the age of 64 is likely to increase by almost 8% by 2035. This is a demographic that my mum has a lot of experience in, and her view is that Medway is run reasonably well. In my experience in other areas, it's not done so well. So can the portfolio holder assure me that it's future-proofed, so that when we get this increase in demand, our record is not ruined by that stage? Thank you, Chair.
Thank you for your question, Councillor Lammas, and thank you for your kind words with regard to the care payment. The point you make about the mental health and the increase that we are seeing, it's for ever since I've been involved as a councillor, there's always been this the talk about the fact that we are all living longer, which is a great story for everybody. That 10 used to be the sort of given age. That's when you would peg it, basically. But things are certainly a lot better now, and we are, all of us, living a lot longer. And with that comes obviously more challenges because this is people's expectation. They want to live longer. We all want to live longer. So this really is a case of we have to make sure that for the future that we are future proofed. And I think that you'll find, and I think from your own words, you've seen that Medway is quite well placed. And this is because that we are constantly reviewing the services that we have around us, not only working with KMPT, but equally our in-house mental health services. And all the time we are pushing forward. Dementia was mentioned earlier, and this in fact comes under this this category, and we're doing our very best to make sure that everybody is aware and doing their part to help support people. I hope that touches on the answers that you were looking for.
Thank you. I was talking specifically about those in receipt of services for learning disabilities. I just didn't know if any others had any comments on that particular cohort.
Well, learning disabilities, that is something that is very much close to our hearts here in Medway, and I believe that we have a very good programme in place that is always under constant review to make sure that all of these individuals, whoever they may be, at whatever age, as they're coming through the system, we have to look after them. We have that responsibility. We have a statutory responsibility to look after them, and that's exactly what we do. And I'm sure there'll be others who might be prepared to correct me, but I'm not aware of any serious concerns that have really been raised over the last few months, over the last few years, or anything that we see coming down the line. Is there anything that perhaps I've missed, Jackie or Leanne, please?
So, no, I mean, Councillor Brake is right. I think just from an assurance point of view, we've just re-procured our supported living service, and supported living tends to be specifically for people who need support in the community with a learning disability. And the way that that's been re-procured is effectively in tiers, so that we can make sure that people with the most complex and challenging learning disabilities are receiving the right support, whereas somebody who may have mild or moderate disabilities receives like a lower level support. So I'm quite confident with that re-procurement that we will get. We've got a number of new providers that will be able to provide that care and support in the community that we need. So Councillor Brake is right. We're continuously reviewing and looking at what we can do to improve. Just one of the things that we're doing internally is I'm about to go out to recruitment for a head of classed as specialist services, but I'm asking for that person to have experience, both strategic and operational, in working with people with learning disabilities, autism and mental health, so that we've got that real overarching view to make sure that we're part of the Learning Disability and Autism Collaborative, which we are, but I want us to have that voice. So I'm quite confident that we'll provide those services. There's always challenges, there always will be, but the way our procurement and contracts are written enable us to flex things, so it just gives us that ability to shift things around a bit.
Thank you. Councillor Purdy.
Thank you, Chair. Thank you, Councillor Brake, for attending this evening. What I'd like to, you spoke very well. We do have some very good things. I think we've got some of the best nursing homes that I know in Medway. They really are outstanding, and I, like you, visit them quite often, and I'm always very impressed. But what does concern me is we are failing in care in the home. And as there is a tendency to want more and more care in the home, I really do think that we do have to do. And as you say, it's a vocation for some people, but we need to, as Councillor Murray said, we need to say to people, yeah, it is a vocation, and we really appreciate it. and you will need, and we should take great pride in them. But I do find that more and more often I go and visit people and they have carers coming in, and it's ad hoc. They don't know what, and I know it's not always easy to say that you can be there at 9 o'clock in the morning because things would hold up. But they could at least expect someone to come within an hour of that 9 o'clock, even if it's 10 o'clock, because it's important to them. They're sitting there in that home, or, they're lonely. They don't see anybody, and that carer's going to come in, and she's an hour late. The world's ending for them, please believe me, and I'm sure you've done exactly the same, Councillor Brake. So yes, I think it would be great if we can actually look at care in the community much more in depth.
No, thank you for that. Your point is noted and will be looked at in detail, Councillor Purdy. You're absolutely right that an hour's delay, half an hour delay, in fact, is a long time in people's lives. But one of the areas that we have improved on greatly, and that in fact is dealing with social isolation. And there's no doubt that one of the things that came out of the pandemic was that this social isolation, in fact, diminished simply because people were talking to each other. And what pleases me is that that contact that we've had in the past or during that pandemic period is in fact continuing. And again, referring to the Medway Champions programme, we heard from one of the organisations within Medway, the Who Cares, that really have done a significant amount of work out on the Who Peninsula to look at and support those individuals who are living in a very much a rural setting and do need that help and support. Now, I know this is not the carer support, and that is obviously the point that you made, but equally, if people know that there are others around that neighbours, friends, part of the organisation, people that are prepared to give that additional support, that really is very, very helpful for individuals. None of us want to be alone. We all want to be part of a community and look for others to help.
Thank you, Councillor Brake, and I do know a lot of things do go on, but you have to remember some of these people are very private, and their home is their world. They're housebound, and as I say, the carer is the important part. You know, you can go and chat to people. I go and chat to people the same as you do, but I can't fulfil that role of a carer. I cannot go there and wash them and clean them and do all sorts of things. I don't mind cleaning the house sometimes, but their personal care is very, very important to them.
Thank you for that.
Thank you. Councillor Price.
Yes, thank you. Thank you, Councillor MacDonald. Thank you, Chair, and thank you, Councillor Brake, for coming along. I wanted to ask you a little bit, first of all, about the report in the agenda. On page 16, it talks about the 3 localities in Medway of adult social care teams. And it mentions locality 1, Raynham and Gillingham, locality 2, Chatham and Walderslade. Then in a separate paragraph, it talks about locality 3, Strood, Rochester and Who, and you go on to talk about one of our most important statutory responsibilities, which I totally agree with, is adult safeguarding. And I'm just wondering whether in the structure, by linking adult safeguarding, as it does in that paragraph with the Strood, Rochester and Who, that locality, whether that's because that's the lead locality for adult safeguarding, is that the reason why it gets its own paragraph, or is it just a way that it's turned out there? And then I wanted to ask you also about the role of community hubs within Medway. Some of those are run through our libraries, so you could argue directly or indirectly via like Medway Council, but obviously the role of the charitable and voluntary sector. And I'd like to urge you, following on from my colleague Councillor Teresa Murray, to do your bit as a portfolio holder to be able to highlight the very good work which is done within our community hubs. And I'm thinking like particularly of mental health services, well-being services, and linking in with what Councillor Purdy was just highlighting, the importance of reducing social isolation. And I also wanted to ask you whether you could also give more of a positive shouts and thanks and support to our carers out in the community, the ones which are going into the private homes, like supporting our older like citizens, and whether you can check with them when you're talking with some of the carer support groups, which are voluntary groups, which kind of help to kind of like look out for the well-being of carers. You know, that the council can be doing more to like promote what is effectively like provided more or less for free, and it wouldn't cost anything just to be able to thank both our like community hubs and those ones run by the community and the voluntary sector, and obviously on an independent basis the role of the carers. And in connection with the community and the voluntary sector, I'd like to praise through this question the help which is being put out there, not only through the Citizens Advice Bureau, but through the likes of Gillingham Street Angels and of course our Medway food banks, because the cost of living is really like upon us as it is in other parts of the country. So again, anything you can do to on behalf of our like community, thank them. And then finally, if I can ask you about what you're going to be doing in the next year. Well, obviously we're looking back to the last year, what you've been doing to address that gap in terms of health inequalities, because you've mentioned about people living longer. That's not necessarily the case when you look at the ages of people in our more leafy suburbs compared to our more challenged central urban wards. And there is that old adage about that you can get onto the 176 bus, and people getting onto the bus, say from Walderslade, I think you represent Walderslade, on average are living 8 years longer, unfortunately, when the 176 bus rolls through Richmond Road and Gillingham North and points east, like heading towards Twiddle, etc. Thank you.
Thank you. Before you begin, I'm told there was a problem with 2.2 on locality. Jackie, could you come in there, please? Sorry, David.
Yeah, sorry. It's a formatting error, unfortunately. So locality 3 should be in the bullet point, and then the paragraph starts one of our most important statutory services.
Thank you very much.
Okay.
Thank you, David.
Right. Thank you, Jackie. You've answered that question. Yeah. The mental health sorry, I'm just referring back to the 2.2 and the questions. Make sure I don't. Yeah. Okay. Right. If we go across to carers and carer support groups, that is something that is excuse me, is high profile within Medway, and we do our very best to make sure that the carers, home carers, family carers and the like, families and friends, that we do recognise the work that they do. They in fact are a very important part of the caring programme, and the truth is that without those very people who were there to support those in need of care, I think the whole system, not just in Medway, but across the whole country, would just fall apart. And we're very conscious here in Medway, and we always do our bit to recognise the work that those carers do, and that could come in by way of support with respite care to give carers that little bit of extra break. To ask if there is anything in particular that those carers actually need to be able to support their loved ones and family members. So they're very much high profile as in our terms, but I suppose it's come to the stage where the work that they do, nothing is ever taken for granted. I think that is the important thing. Nothing is ever taken for granted, and we always make sure that we look after them. But if there are any concerns that come to your attention, then please do let us know, and we'll jump in there and help sort it. But to my personal knowledge, I don't think we're aware of any real major issues when it comes to those carers, because we do care about the carers and look after them.
No, I suppose, like through you, Chair, I was really wanting to link the point which my colleague Councillor Murray mentioned about giving more coverage within our social media through like Medway Matters, for instance, which goes through the like letterboxes of every address within Medway, just to like celebrate what they're doing, but also to thank them, and obviously to make sure that things like you mentioned respite care, whether we're as a portfolio holder, you know, you feel that we're doing enough to be able to give that respite, because sometimes they just need that little bit of the extra break from what they're doing to be able to come back and be more like refreshed. Thank you.
Okay, thank you. I think really you've covered.
Yeah, and
said,
then
what are we doing?
And then there's the point about the health inequalities. Do you recognise that there are health inequalities within Medway?
Right. Okay. So I think I thought for a moment my battery had gone flat, but it's it's woken up. Yeah. Health inequalities. Yeah, this is an area that is constantly under review. This is again, we are victims of our own success, in as much as that to me it's ongoing work. And all the time we're looking at where we are today in certain areas, and I think the 176 bus that you mentioned, if we had a 176 bus that ran all over Medway, we would be a lot better off. I would agree with that. But the fact is that we're all the time reviewing the situation in all of the areas across Medway, and if there are areas of concern that you have, that you think that we're missing, then please do bring it to our attention, and it will get our attention. But as far as I'm aware, and I shall turn to James as well as Jackie and say that if I've missed anything here, then please give me the support, or if there are other things that we should be doing or I've missed out, then please add to it. Thank you.
Yes, maybe through you, Chair, I could take up Councillor Blake's offer and ask James Williams whether that gap between suburban and urban wards is still 9 years in terms of life expectancy, and obviously from an officer point of view and a public health point of view, just to add to Councillor Blake's offer to do everything like necessary if there are any areas of concern. So just to give you that opportunity, because I'm sure there is some good work going on.
Thank you, James. If you would please.
Thanks, Chair and members. I think we'd all recognise, won't we, that the challenge that we've got now around health inequalities is not just about the difference between wards, it's actually within areas, and we are quite clear about the way in which we need to tackle that. We've had, how can I put it? In fact, all right, I'll say it then. So we are now the best area in the South East in relation to NHS health checks. We just had the recent data, and our programme has delivered over a 5-year period more health checks, and that identifies people who are more likely, unfortunately, to die for causes that are not related directly to communicable diseases, so infectious diseases. These are things such as diabetes, heart disease, and actually the point that was made earlier on in terms of dementia. We've got now some of the lowest rates of smoking prevalence across Medway as recorded. Clearly, there is still more work for us to do, but it does mean that those areas that what Councillor Johnson's talking about there, some of our more disadvantaged communities, we know that the prevalence of smoking and other things, whether it's obesity, diabetes, that will give rise to premature death are highest. So we are doing that work. What I would suggest, though, is that members recognise that 80% of the impact on health outcomes relates to wider determinants, not clinical interventions. And this means that it's a longer term journey. We're currently in the process of refreshing our joint local health and wellbeing strategy, and that will come to this committee clearly for consultation. But equally, we've just signed off the interim integrated care strategy, and I don't want to steal any thunder from some of the reports that will come into the committee, but if you notice, Chair, that we did talk through that the last time. So just in terms of reassurance, we are aware of those challenges. We do try to bespoke the work that we do. And Medway, as you know, hopefully members will recognise this, we are the first area in the South East to become a health determinants research collaborative. So that gives us over £5 million, starting from October this year, of course. But we've got some of that resource now to build our capability to do more within those spaces. So we recognise it, hear what members are saying, but we do try to endeavour to do what we can. And my final point, just in terms of linking in, I think Councillor Johnson, you were talking about the food insecurity and things like this. So we've given grants out to our local charities. Some colleagues, I know members in this room are a part of that process to ensure that we can feed people now. And clearly I know there's a few members' questions that will be coming up into Council about the warm home schemes and stuff like this. So I'll leave that to full Council, but hopefully we're doing as much as we can.
And like finally, thank you, James.
Thank you. Can I just say, James is the Director of Public Health?
Yeah.
Because there's not a camera
Okay.
pointed anywhere towards you. Back to you, Councillor Price.
Yes, I just wanted to thank him, take the opportunity, because I'm going to thank also Councillor Clive Johnson for the work that he's done as our spokesperson on children's and young people. But my name's Councillor Adam Price. I know you referred to me like a couple of times as Councillor Clive Johnson, but Clive Johnson is going to be standing down, and I wish him all well in the future. Thank you.
Thank you. Councillor Griffin.
Thank you, Chair. Good evening, David. I've got a very short question to ask you. I have just come onto this committee. I haven't been on this committee for a long time. But reading the papers, my question is, do we still give support to our young carers? That's it.
Thank you. David.
Thank you, Sylvia, and welcome back to this committee. Doesn't seem all that long ago that you and I were working hand in glove on this very same committee as chairman and vice chairman. Oh, so welcome back. Young carers, in fact, is something that has always been very dear to my heart, and in answer to your question, a very short answer is yes, we are still supporting young carers. It's a very important part of the programme, and it's a very important question that's been asked, because the young carers are usually those that perhaps aren't familiar with the young carers and what they do. They do, in fact, are very supportive of family members. And these young carers are looking after their parents and grandparents and aunts and uncles. And my experience in involvement with these young people is that they wouldn't have it any other way. They want to be involved with their family. It's all part of their upbringing. They're very much there. And of course, the Young Carers Programme, by us looking after those young carers, the message that we can put across to those young people is very clear. We are here to help you support the elderly people in your family, whether that be a parent or grandparent. And in doing that, the electronic systems that are available now within homes that push button alarms and the like, there is no reason why a young person should have to stay at home all of the time to be there for an ageing relative, because they can go out and they can recover some of their life. And that's always been the objective, to make sure that they can lead a normal life as is possible, but a normal life that they want to lead, because they care very much about their family members. And of course, I do know from experience that that the schools are very much a part of the programme, because sometimes these children are late for school in the morning because of something that may have happened during the night, or perhaps there's been a homework problem. So it's incumbent upon us to make sure that the schools are aware and they also support the young carers. Okay, thank you.
Thank you. Now, there are still 2 more members, and we do have lots more on the agenda, so if I can ask everyone to be to the point, please. And Councillor Van Dijk. Thank you. That's definitely to the point. Councillor Turpin.
Thank you, Chair. Yeah, my question's fairly straightforward. Thanks you, Councillor Brake, for your attendance. I just wanted to go back to 4.2 and the 705 people that it mentions we support. I'm not sure if that number, it seems sort of relatively low, but maybe it's not, and you might be alarmed by me saying that, I don't know. But I wondered if we sort of compare, I assume we compare that sort of figure to other local authorities and with, you know, percentage of population, all that kind of thing. So I'm just mindful that we sort of, yeah, the learning disability, that we're aware that, because where it talks about a larger increase predicted of 7.9 by 2035, I'm just sort of, with it, you know, obviously it's been no secret that we've had challenges in our children's services over the last few years, and I'm just sort of worried that, you know, are we confident that we're providing a service to all the adults out there that need support, and are there going to be sort of more coming through into adult services where they've sort of been maybe gone through the net in children's services, and there could be an even bigger increase in years to come? Thank you.
Thank you for a very interesting question that you've asked there. And I think that the answer is clearly that if we collectively were to deal with the younger people that have the difficulties, and we pick up with those young people and we work with those young people, that in fact is going to be of benefit to the adult services in the future. But that really is going to take time to sort out. And I've been involved in a great deal of discussion with my counterpart on children's services, with Councillor Isles and indeed Councillor Potter. And what we are looking to do, in fact, is to make sure that we get the right resources in at the children's services so that we can overcome those problems and work with the younger people, such that when those younger people then go into adulthood, that hopefully the problem isn't going to be as big as it is today. The problem we have today in adult services is very simply because as children, many of those individuals, those adults of today, were basically not given the care and attention that they should have had when they were children. We in adult services are now having to look after those people in adulthood and working, and the cost associated with those into adulthood is far greater than if we were to have been picking them up as children and dealing with it at the earliest possible time. I hope that answers your question. Is there anything that Jackie or Jackie, is there anything you'd like to add to that, please?
Thank you. So just to comment, the 705 people with a long-term patch care is the primary support reason of learning disability. So when we assess people, we have to categorise, it's horrific, but we do have to categorise people. So it may well be that somebody's primary support reason actually is that they have a physical disability, but they also have a secondary disability of a learning disability. So the 700, it's higher than that. but from a primary support reason, that's where the 705, and that's the numbers we have to respond, we have to submit to the Department of Health and Social Care.
Thank you. Are you happy with that, Councillor Turpin?
Well, just sort of, is there confidence that we're sort of covering, I don't know, perhaps maybe to Jackie, if that's fair, if that's okay, that we are confident that we are supporting, you know, the people that we need to out there, and that there aren't people that sort of are just not coming forward because they're not aware, or that it might be still that they're living at home and parents are still coping with them, but there's going to be a time when the parents are too frail to cope with them, that kind of thing.
So I wouldn't be able to say we were 100% confident that we are capturing everyone, and we certainly come across cases. I mean, people will know of Berlin Avenue, our in-house respite centre for people with a learning disability, where actually from a crisis perspective, we find out that there is somebody that's been living at home with mum and dad, they're in their 40s, and then something happens to parents, which means they end up moving into that respite provision. I mean, the work that we're doing from a population health perspective, that is looking at how we can identify people and reach out. I think the other thing is there are people with a learning disability that actually don't meet adult social care criteria, so they get support from our health partners but may never need support from us. So it's trying to find the balance between the two.
Thank you, David. Councillor Purdy.
Thank you, Chair. Thank you. I move that we thank Councillor Brake for his attendance. Oh. I thought I'd got a big enough mouth anyway, David. I move that we thank Councillor Brake for his attendance and note the report.
Thank you all very much for your time this evening. Thank you.
As always, I've got to ask, is that seconded? Thank you. Robbie. Right, thank you, members. That takes us on to agenda item 6, which is South East Coast Ambulance Service update, and we welcome Ray Savage, Mark Webb and Lawrence Sopp. Is that, yes, thank you.
Thank you, Chair. It's Matt Webb, just for point of clarification, but
I'm sorry.
that's fine.
And can I mention, I'm told that safeguarding isn't mentioned in the report, so when we come to recommendations, we will ask for a paper on safeguarding aspects. So
Yeah, absolutely.
just making members aware of that early on. Right.
Thank you.
And with that, over to you if you could give a brief introduction.
Okay, thank you very much, Chair. And again, it was March of last year when we were here last, so thank you for inviting us back again to give another update. So I'll take the report as read, but would like to just highlight a couple of points, well, a few points if that's okay, from the report. Since we were here in March, I think it would be fair to say that the operating environment that we're in has remained challenged across both 111 and 999. There are some difficult stories in that, but there are some good stories as well. in as much as with 111, we're still a high performer with direct access bookings. So that's where we're able to book patients directly into other services when they've contacted 111. And ambulance validation, we're a high performer. So when somebody dials 111 and it results in an ambulance dispatch, category 3, category 4, we're validating about 95% of those incidents and reducing the number of ambulances by about 50%. So on those two fronts, we're doing fairly well. We are challenged around call volume, and of course that has led to challenges with call abandonment rate as well in 111. 999, our category 1 performance, and of course recently in the media there's been a significant amount of focus on category 1 and category 2 performances for the National Ambulance Service, so the 10 ambulance services across England. Category 1 for November, we're just outside the national mean. Actually, Medway is a better performer compared to the rest of CCAM for Category 1, and the same for Category 2. But for Category 2, we are a better performer compared to other ambulance services. I say that carefully because we're still not meeting the national targets, and we totally understand that, you know, part of our drive and our improvement journey is to improve on those times. I'll touch just briefly on ambulance handovers. And again, there's been tremendous media coverage around delayed ambulance handover. That's no different for ourselves. However, compared to other ambulance services, we are in a better position, particularly here across the 4 ICSs that we cover. And I think, and I know Jane's got it, excuse me, at the beginning of her report, she touches on ambulance handovers at MFT. Just want to highlight that from November into December, ambulance handover delays up at MFT have significantly improved, and there is in one of the appendix there is a chart that actually demonstrates that, and that's through the work that MFT have been undertaking and how we've been working with them. We've also been focusing on the number of patients we convey, and we have reduced the number of patients that we are conveying into the acute trust. And again, that's been achieved through partnership with Medway Community Health, and as it is with Medway, we have one of the higher numbers of actually referrals into community services when ambulance crews are on scene compared to the rest of CCAM. So there's a couple of, you know, real positives in amongst some challenging performance numbers. We've mentioned safeguarding, and I'm just going to touch briefly on the industrial action. Working with our union colleagues and through derogation, we have been able to provide, you know, good levels of cover to Category 1 and Category 2 responses. We have seen a reduction in 999 calls coming in compared to what we would call a normal day. But however, you know, working with our union colleagues who have responded from the picket line, we've been able to ensure that certainly those patients in the Category 1, Category 2 response groups have actually got an ambulance response. And I think I think that will be my few points, if I may.
Thank you. Just a personal comment, which, well, I don't know if I should say or not, but 30 years ago when there was industrial action on the ambulances then, my son started to choke, and strike action or not, an ambulance appeared and we got the help we needed, and, you know, he's fine, and a pain, which I probably shouldn't say that now, but, you know, 37-year-olds tend to be that. Right, so yes. So in spite of the industrial action, you know, we're all very pleased with our ambulance staff, or personally I am. Right, moving on, Councillor MacDonald.
Thank you, Chair. Welcome, Ray. Like I say, Chair, I will keep the questions pretty succinct because there are 3 members there, so maybe you can all write down the answers as if I fire them all at you. Can I first of all say, though, I see you brought plenty of people with you, Ray, in case I overgate you, because you know what my question is like, but I'm going to be very sympathetic tonight, honestly. Can I first say, though, that your team do an amazing job? You know, I mean, you know I was there with Will. When Will was up there, I was always supporting the team like many other councillors do. And there's no doubt that your frontline staff do an amazing job. I want to say that first before I start on the internal aspects of your organisation, okay? Can I just ask, the first question is about the service now. And, you know, you said about the industrial action, but I'm talking about the actual service because it's been very stressed since, even since October, November time. Do you feel that the service is in crisis at this moment in time with regards to... Do you want me to ask you questions, then come back to it? That might be easier because the chair might be happy with that rather than keep coming backwards and forwards. Can I ask you what your current sickness level is at the moment in your service, bearing in mind it was 10% between February and July 2022? So I'd like to know what your current sickness level is on the stats you have up until your last, whatever you do. By the look of it, you do sort of a 4 or 5 month stat, so whatever they are up to now. Of course, I was disappointed to see the CQC report. Extremely disappointed as well, considering that we've had many reports to this committee and we've been reassured about the bullying, we've been reassured about the staff morale, we've been reassured that the new administration, the CEO at the time coming in, the new management was going to do an amazing job. And when you read that report, again, not taking away the great work on the front line, when you read the report, it just seems that there was nothing's been learnt internally. And I'm going to say at your executive level, you know, yes, you have an immense staff a team, you have loads of staff members, it's not easy. But when your CEO goes on the press and on the radio in October and says that, you know, she said that she was not happy with the pace of progress of your progress from that CQC report, and that never before has she seen a volume of employee relation cases. Never before, and that's your interim CEO, just near enough the end of October time. That's quite worrying, isn't it? From not from your normal, I say your normal because councillors are normal sometimes, but not from your Joe Blogs on the street who just wants to pick up the phone and get an ambulance to them. But when you look at the state of play with regards to your employees, it is concerning. So I would like to know from you, do you feel that the tide is now turning? Your honest opinion on that. Do you feel it is turning? I know you're turning a big ship there, but is it actually going in the right direction? A quick one is, what does the statement, the well-being of our staff is a key focus for the trust mean? Does that mean that you will look at that reduction in bullying? You know, we look at staff well-being areas, for example, and yeah, you mentioned about Slimming World. You don't mention that a lot of your staff have eating disorders and other issues, but we talk about Slimming World vouchers. That's a key thing for, I'm sure that's not a key thing for your staff when it's clear that, you know, on the last survey that was done with your staff are, and in the CQC report, your staff are burnt out, your staff are working beyond their hours, and your staff are not getting breaks at the correct time. The last thing they need is Slimming World vouchers. They need actually care and attention to make sure that they get those breaks and they get that, you know, to lift the morale. So I'd like to know around your wellbeing areas, especially some of those wellbeing areas that have been in since 2017, and we've discussed at this committee many times. This isn't just something from COVID time, this is from 2017, where we've been promised that things will change. Obviously, can you tell me again that this new emphasis, this new focus on your 6 identified themes and your staff wellbeing is going to allow your staff to turn around and say that CCAMS is not a great place to work, because that's what they're saying. So you know, they're the questions, Chair, if you want to come back for clarification at all, but it is mainly around your staff, the treatment of your staff and how they are treated by your executive. That's what I'd like some reassurance on.
Thank you, Councillor MacDonald. I'll start, and then if that's okay, I'll hand over to Matt for further commentary. I think, yes, we were all incredibly disappointed with the CQC report, and in this report that I've written for the committee, I have emphasised the CQC report, the improvement journey, and the well-being measures that we've had in place and are putting in place.
Sorry, Ray, can you pull your microphone Some members are saying they can't hear you, sorry.
Is that better? Okay. Yeah, okay, thank you. So I've emphasised in the report, particularly those three areas, CQC, improvement journey and wellbeing. Slimming World Vouchers, it's one of a range of wellbeing measures that we have in place. So I included it because it's one of a broad range of measures, because we do take our staff wellbeing seriously. And all those measures are in place, from the counselling, the physiotherapy, and that broad range that I've listed. It's about trying to provide our staff with a broad range of services that they can access, including money matters. There's a broad range. So we're trying to reach out to staff at all aspects of their lives. Obviously in the workplace, but of course, you know, in their personal life as well, and giving those opportunities. If we can help them in the workplace with their personal life, then that's what we're trying to focus on. I think, going back to the point you said, I think the CQC did recognise, and you did touch on it, and thank you, about the excellent service that our staff are providing, and the CQC did recognise that, and I think we were really pleased that they recognised that, because our frontline staff are working incredibly hard, absolutely right, and that was an acknowledgement. And you're right, the target of the criticism of the CQC was primarily at the senior team, so the executive team, and the disconnect between the senior team and frontline staff. And the improvement journey is a detailed improvement journey plan that we are working on at pace. And if I hand over to you, Matt, is that okay to pick up on how we're responding to the CQC?
Yeah, thank you. Just before I do, actually, Councillor, just the targets, the metrics, the data you were asking around sickness. So we aim to run at a target of 7%, no more sickness organisationally. Within the operations and service delivery arm of the organisation, at the moment we're 10.57%. So there's a considerable uptick that we've recognised. I think what I would say is that isn't dissimilar to what we saw last year, but we were in a different place last year with the prevalence of COVID-19, etc. We're not an outlier organisationally with regards to sickness, and actually what we are seeing across the NHS is an increased prevalence of burnout and mental health concerns, as you've just rightly identified and Ray's just touched upon. With regards to the improvement journey, so you've made reference to some of the comments by our Interim Chief Executive. What I would say is that some of the comments were in relation to the Trust, some of the comments were in relation to the national landscape and the ambulance sector generally. But you're absolutely right, and we have acknowledged through the improvement journey that CCAM was not the great place we wanted it to be. There have been concerns raised previously, and clearly we've not maintained and sustained the improvements that were demonstrated. Trust in leadership has been reported as low throughout the last 12 months. There's been disconnect between leaders, disconnect between the board and the wider organisation in particular. The golden thread of quality was another concern, which then concerns patient experience, patient safety, not running through the organisation. And I think most concerningly, and the reported back from our staff, is a lack of clarity, consistent vision, direction of travel. Now, not making excuses whatsoever, but the thing I would like just to highlight is that both the NHS staff survey and the initial CQC report, where we ended up in what was formerly known as special measures, the inspections were undertaken still in the response phase of COVID-19. So we had to make some really challenging decisions during the COVID-19 pandemic. We operated at our highest level of escalation throughout most of the pandemic, and that does involve cancellation of statutory mandatory training in some instances, cancellation of professional development. That involves challenges around staff having meal breaks. It involves extended overruns of shifts, and we tried to prevent, mitigate, control and avoid that as much as possible, but I'm sure we will recognise the demands of an unprecedented event, which we're continuing to recover from. With regards to our response to the CQC report. So following the February report, the organisation was identified following a well-led inspection as inadequate, and that was the rating we were issued. That was for the well-led component, of which I'm sure you're aware, there's 5 CQC standards. And our remaining rating for the other 4 standards was suspended because the CQC couldn't be assured around the other 4 standards. In answer to your question as to are we moving in the right direction, We had a subsequent visit in the summer and a follow-up report from the August visit in October of last year, and our rating was altered and improved to requires improvement. So that hopefully gives you an indicator that we are moving in the right direction. I think the assurance I would offer to the committee is that we were issued with 4 warning notices around board effectiveness, around governance of the organisation, risk management and culture transformation. They were due to expire on the 18th of November, and to date they've not been extended, they've not been renewed, we've not had any additional warning notices placed upon us. So again, they are indicators, although the CQC will be returning later this month, where we'll understand our position in greater detail. What we need to recognise as an organisation is that culturally we're not in a healthy place, and I've mentioned that in a couple of recent HOSC and HASC meetings, but culture change takes time, and that's what we recognise, and perhaps that's what we didn't get right last time round. So actually, if we and we've done some root cause analysis as to how did we end up in the position we ended up in, and actually what we didn't do is the maintain and sustain piece. So actually what we need to recognise is we need to commit and invest in the time it would take to change the organisation, but there are quick wins, for want of a better term. There are things that we can absolutely do now. One of the changes in our focus in the improvement journey, which is made up of several programmes and work streams around people and culture, responsive care, so the operating model, around board effectiveness, sustainability, etc., is we now recognise that we need to move the organisation from a regulatory-driven organisation to a strategically driven organisation. Unhelpfully, the 4 warning notices that I've made reference to have little palpable impact to staff on the ground. So to your point, the impact right now is around they're not consistently getting meal breaks. There's extended overruns, there's demands, hospital handover delays are impacting on personal resilience, etc. So now that we've prioritised the warning notices, we're now seeing a shift in our improvement journey. And for the next 12 months, we need to absolutely focus on quality of care, quality within the organisation and our people. And they need to be our 2 primary priorities throughout the next 12 months. There's a lot of detail we can go into around the improvement journey CQC report. I'm more than happy to come back to spend some extended time to go through that, but hopefully that offers you initial assurance as to how we're progressing.
Are you in crisis? I haven't had the answer at the moment about is the service in crisis at this current time?
I think what we've learned throughout the last 24 months is the definition crisis is a difficult one, because we've gone something through unprecedented that we've not seen before. What I would say is we're in an extended recovery period, both organisationally. Unfortunately, we've had the additional challenges identified that we're working through, in addition to COVID-19, in addition to industrial action, in addition to the national context, national landscape. So what I would say as an organisation is we're in an extended period of recovery. There have been several challenges we've identified. At this moment in time, I would say that we recognise the instability that we still have within our executive team. We have executive members that are in interim positions. However, we are further forward than where we were 12 months ago. We're on a journey of improvement. So perhaps we were extremely challenged this time last year, but we're on a trajectory of positive progress. And we need to look at this in the context of the national piece as well. So we know the issues with the ambulance service nationally, and we can see the pressures that the UEC sector is under.
Chair, the final point, and I'm closing that. So thanks very much for that explanation. That was really, really helpful. I just wanted to make the point, though, and I know COVID was very challenging for all, and I know it will be for when we get to the MFT as well. COVID was a clear challenge. The only thing is that the cultural thing, the bullying, the staff burning out, and everything else was before COVID. So we can use COVID and that, and I'm not going to say use it, because it's a, you, like I say, and I'm not going to keep saying it, you've done tremendous work. But COVID, we tend to go back to COVID, which is right, because it is a real figurehead, isn't it, in all of your services, because it really turned you upside down. Although you delivered, it turned you upside down. But I don't think we can get away from, and I know you wasn't, Matt, you wasn't trying to get away from it, but I don't think we can get away from the fact that the cultural change that we've been promised is going to happen has been from 2017, 2018, 2019. So, and I think you recognise that. I just don't want us to think that the cultural stuff was because of COVID. It was there before, and and I'm hopefully the executive team do recognise that.
I think, Chair, if I just may just offer assurance there, absolutely the points I was making around the trust not being the great place we want it to be, and so on, recognise that COVID was an exacerbating factor, but our root cause demonstrates that we were in a better position prior to COVID, at the start of COVID, and there has been a decline for some reason that we are unpicking through the improvement journey. So we're in a healthier place, but we certainly have a journey to continue on.
Thank you. I don't think, well, I agree with Dan. I don't think there's words you can say that's going to take away from the bullying aspect simply because it's gone on so long and we've been given assurances again and again. So, you know, that's a comment, not a question. You know, yeah, but a shot, yes. But, okay, thank you. I'll move on. Councillor Lammas.
Thank you, Chair. My line of questioning is on a similar theme and all focused on the culture. I thought, can I just give all my questions in one and you respond at the end? I have one short question, which is, do you have the data for the mean for the C4 999 performance responses? And is there a reason why it's not included in point 4.3 on page 57? If there is an obvious reason for that, I'd appreciate it. That's just a small question. Reading the report, it seems to me that there's a lot wrong about leadership, and the issues are not about necessarily COVID and the kind of pressures that we're experiencing nationally. For example, when you talk about, when the report says about, you know, there's persistent periods of time where demand is outstripping what has been planned for by the service, that's a planning and management failure. When you read things that staff are persistently doing overtime, that's a failure to recognise the conditions as they are per shift, which if you know they're going to be bad and you know staff are going to do long, you need to recognise that and ensure that that's rotated in. So the bad position is formally recognised in the rotating system. That is a poor management and leadership problem. When the CQC reports find that they can't see any visibility of management, that is a management and visibility problem. So my questions are about, have the managers and the leadership got the gist of the issue here? Because when I look at some of the stuff to do with your improvement plan, I'm not overwhelmingly convinced by it. I mean, you mentioned the 6 themes that urgently require addressing. They're basically about trust in leadership team. And yeah, you've got people and culture, but why isn't one of the points just called improving trust in the leadership of the managers? It seems really, really washy. And also, when you look at the actual breakdown of things you're doing under people in culture, which is what I'm mainly concerned about, it says the trust board has undertaken over 100 site visits. Does this mean that there's not a routine expectation for board members to be on site, one board member to be on site at any one time? Is that not the norm to have the top leadership on the front line as basically a zero? It talks about things like zero tolerance to inappropriate behaviour until it stops campaign. What on earth has been allowed to go on beforehand? If you have to have a zero tolerance programme for inappropriate behaviour, that means that inappropriate behaviour was persistently going on. And then the thing that really shocked me was in the bullet points under people and culture, you've got one about how communication with staff has now had a refreshed focus on concise e-bulletins. I mean, really, like when they're talking about lack of trust in the leadership, lack of visibility, you'd honestly think that you'd want a manager to be present on every shift so someone has someone who can speak to, not have to go log on some god-awful, ill-designed internal portal, no doubt, to look at the latest e-bulletin. And then even the CEO is doing communications by videos, as opposed to actually having a known monthly all-person meeting or a known team meeting, because obviously you can't get all staff all together at one time. If video updates is the only way the actual chief exec can actually speak to his people or her people, then what on earth is going on? So I would basically just like assurances over, does the leadership actually know what they need to do to actually make these people feel valued? Because I don't buy the idea that these issues are all to do with COVID. I mean, I've experienced examining the performance of ambulance and trusts across the whole of England in my career, and some of the issues I see in this report and reading between the lines are actually specific to the trust. So have you really got the grips of the problem? Are you going to start being there on the floor with your staff? And are these management failures of planning to plan for demand appropriately staff consistently doing overtime, lack of speaking staff, lack of visitability. And the final point, Chair, is, and this is emblematic of not listening to staff, is what happened with this pausing of the Fiat ambulances refurbishment programme, which the Trust paused, because staff were raising concern about a number of features on the type of the ambulance. I mean, the ambulance is literally the primary piece of kit. If you're having to pause the refit because you're not listening to staff's concerns about ambulances, I mean, what happened there? Thank you, Chair.
Thank you.
Councillor, could I just ask a question? So just so we can articulate the answers in the best possible way for the forum. You mentioned that some concerns are specific to the Trust when you've been benchmarking and comparing to other trusts. Are you able to just articulate or clarify for me what you want us to focus on there?
What I mean by that is that when I look at reports about ambulance services in the east of England, or those serving the northeast, or those serving the southwest, they all have issues which sort of are considered national issues. But I don't see problems of lack of visibility of management. I don't see problems of having to pause a refit programme because there's some problem with the Fiat ambulances. I don't see problems of persistent shifts going over time where they're not factored in. If you get what I mean by that. So everyone knows that the handover situation is in crisis, and I appreciate that, and that's not acceptable, but it's understood. But what I'm trying to say is that if Joe Bloggs knows his handover is going to take an hour until further notice, until nationally it gets sorted out, why are they being rotated half an hour for the handover constantly and having to basically work for free or do overtime when they don't want to do? Those kinds of things, what I'm talking about.
Thank you. I'll start. There was a lot there, so I'll try and answer the points you raised. And please, if there's any we haven't answered, and I'll pass to Ray and answer in a second. Then please. So the first point I captured was around demand outstripping resource, and that being a planning concern. I think you certainly picked up on one of the key factors that is the greatest challenge there, and that's around commissioning and financing. So what the issue we are challenged with at the moment nationally, but also within the South East, and not just the ambulance service, but within across the NHS, is around retention, turnover and attrition. So actually, when you look at our recruitment plan, recruitment trajectory, actually we are reasonably on target with regards to recruiting into the organisation. But what we've seen since COVID-19 is an increase in attrition and challenges around retention. Now, I can go into the mitigations and controls, if helpful, in a second, around what we've been doing around that. But when we've undertaken a thematic analysis of exit interviews, since COVID-19, there has been a clear change in that staff want to focus on personal resilience, personal well-being, and they don't feel at the moment that the sector is positively contributing or supporting that. When I referred to commissioning challenges, we're working with our commissioners to ensure that we are commissioned in the most effective way, and we have have sufficient hold time equivalents to respond and meet our ARP targets. We're also ambulance response programme performance targets. We're also working with commissioners and stakeholders, wider stakeholders, to look at what does the operating model need to look like. Because actually what we have seen is a change in core acuity. We've seen a change in presentation. And actually a number of ambulance services nationally are still focused on what the ambulance service was set out to deliver in the first place, which is a transportation function. So something we're also looking at to ensure that we can manage the demand in a more effective, efficient and productive way is to look at actually maximising the use of hear and treat, virtual assessment management consultation, and then looking at actually how we then supplement that with physical resource being dispatched to incidents. I think the second point you mentioned was around visibility and the leadership team not being visible. And again, by no means offering an excuse to where we are. And I've already articulated that the organisation was in a challenged place before COVID-19. But the inspection took place in the response phase of COVID-19, and at the time, and I'm sure colleagues will remember, there was a national instruction mandate almost that if you were able to work from home, then you should do so. We were trying to ensure the safety of our clinicians, and we couldn't have additional non-clinical foot traffic, footfall on trust sites. What that meant was that our visibility, our leadership engagement was primarily delivered through the likes of Microsoft Teams, Zoom calls, etc., videos. It made it extremely challenging. And so, yes, we had challenges prior to COVID-19, but again, that was an exacerbating factor. I think the other thing I would just like to highlight as part of that is the ambulance service setup is very different to other provider organisations within the NHS. And what I mean by that is the estate, the geographical footprint that we cover. So actually investing in videos, interactive e-bulletins, etc., has been positively received by our staff, because our staff typically only spend about 30 minutes of their day on their ambulance station at their Make Ready centre. 15 minutes at the start of the shift, 15 minutes at the end of the shift, perhaps, and obviously they'll have their meal break in the middle. But otherwise, and Lawrence may be able to, or may want to add clarity to this in a second, but they are working in the pre-hospital environment. So it makes it really challenging to ensure effectual, optimised engagement of our leadership team with our clinicians, because they are in the community or their emergency departments. What we are doing, just to offer hopefully some reassurance around this, is we're working with a communication and engagement specialist at the moment as part of our improvement journey to look at how we can, again, optimise and effectively engage and communicate with our staff members to make sure they're supported and to ensure that we utilise all appropriate communications channels. It's not just around communication, though. As an organisation, the feedback from the organisation we're currently working with and from our commissioners is that actually the organisation is fairly good at communicating. It's the engagement piece, it's the listening piece. So actually what we need to get better at is the two-way feedback piece. So actually, how can our staff contribute to the improvement of the organisation? How can our staff offer initiative proposals? Because actually, our frontline clinical workforce, our frontline staff are there on the ground. So actually, if we're looking to make incremental improvements or transformational change, the best place that can come from is the front line, where actually the challenges are being faced. So that's around the visibility part. And then I think there was a third point around the calling out the culture of bullying and concerns around the leadership piece. The warning notices and the headings within the paper and the report that Ray has provided are just aligned to the warning notices themselves. But I would offer assurance and reassurance that we absolutely are calling out the approaches that have previously been taken in the organisation and that they need to improve. And as part of the CEO's engagement interaction that you've mentioned, both internally and externally, we've absolutely acknowledged that the leadership, visibility, engagement, etc. needs to be better. I think the last point I would make around the leadership piece is that you've mentioned I think it's the 100 visibility or leadership visits that we've undertaken. That is in addition to what we would commonly be undertaking, but the point of those visits is to do what I've just said, which is to get out and listen to staff and understand what the issues are. And actually the feedback, as we discussed earlier on, is actually not that they want to see a more effectual board, or that actually they're interested in risk management and governance of the organisation. Again, it's concerns around having to wait in the back of an ambulance with a patient for up to an hour. It's concerns around their colleagues not having meal breaks. It's concerns around, as you mentioned, overruns, extended shift times. The last point I'll then just pick up is around you mentioned the fleet, the Fiat piece. Interestingly, perhaps the reason that there hasn't been so much communication and insight into other organisations undertaking a similar pause is because CCAM are one of the first to do so. And what you may be aware of is the move to the Fiat vehicles was part of a national fleet specification. So there was a fairly robust and structured specification around what the Fiat should look like, structures, physicality, etc. Quite quickly, we recognised that once we started to introduce those vehicles, our staff felt they were perhaps not fit for purpose, or they were concerned around actually the effective use of those. So we made a decision as an organisation, working with our union colleagues, to pause the programme, to work with Fiat, to work with the fitters of those vehicles and other ambulance service trusts to share learning and to make improvements. And actually, we're now introducing adapted vehicles based on the feedback that we've received from staff as part of that programme. So what I would say is, organisationally, the feedback from staff is that's been seen as a positive, because it's the you said we did. We've demonstrated that actually it's an example of listening to staff, taking their feedback and not just making organisational changes, but actually escalating regionally, nationally, to ensure that other trusts in similar positions are aware of those concerns that have been highlighted. So I think I've summed the points, the concerns you made there. I think the only other one I had was the Category 4 mean, which Lawrence and Ray may want to add to in a second. We can absolutely offer that to you. The National Ambulance Quality Indicators and Performance data also was released this morning, so we can share that as part of the follow-up if helpful.
Thank you for your response. So is it the case you just don't have the C4 data to hand?
No, if you want me to offer the C4 data now, I can absolutely do so.
Yeah. What is the mean?
So I'm not going to give you the mean for the last 24 hours because it was clearly skewed because of the industrial action. So the mean for the month to date is 5 hours, 4 minutes, 49 seconds.
And what is the national average?
National average, if you bear with me, I'll pull that up.
Because that's just... I would just very, very, I guess, politely come back to you on a couple of things, but I don't expect an answer. Is that you mentioned about, you're proud about investing in e-bulletins, and then you go on to contradict yourself talking about how the communication needs to be two-way. Then you go on to say, because they're geographically mobile, your workers, it's hard to reach them. But then you go on to say the only time they're actually at the depot or whatever is at the start of the shift and at the end of the shift. So therefore, I would suggest you just have your managers there at the start or the end of the shift. So you can ask them, how are you doing today? Good luck on your shift. And you ask them at the end of the shift, how did it go? What can I take back? And you have KPIs like these managers who are there collecting the data, they have to return to the senior leadership a certain number of recommendations per day. Even if they're the same recommendations over and over again, you're going to be able to ensure that that is taking place. I would suggest that two-way in-person communication is the best way to ensure that you reach that. The other thing I'd slightly push back to you on is the plan for demand. My point is not that there is higher demand. There's a difference between that and planning for higher demand, i.e., if you have a terrible situation, but you have 20 ambulances or whatever on call one day, and it was tough, the next day, you make sure you've got staff on for 22. If you consistently row to 20 on, and they're feeling excess demand because they're understaffed from the available pool that you have on the pressures on the day, that's the point I'm trying to make. And that's the difference I see in some other trusts where, they know that there are lots of big pressures, and you very well eloquently talk about the national picture, and I share those concerns of you, I really do. But it doesn't mean to be that there can be room for planning problems. You know what I mean? That's what I meant by that, because when you've got 1 in 10 off sick, that's an indication of massive burnout. You know what I mean? I know you've got a limited pool of people and you're trying to recruit and retain, but rotoring can make a massive difference. You know what I mean? And ensuring that those excess handover times are rotated in so they can plan their lives better. Thanks, Chair.
Give the member a chance to answer.
So, okay, so I think I've captured a couple of bits there. The point I was making, Councillor, and perhaps where there was some confusion, and apologies for that, around some positive elements and some areas we need to work on with communications and engagement, is the feedback from commissioners, from staff, and from the independent organisation we're working with is communication. We're in a good place because we've got a whole medium and range of communication. The challenge is around engagement, which is then the two-way piece. So actually the messaging is going out okay. It's the two-way feedback and the messaging coming back. With regards to visibility, I acknowledge your concerns. What I would say is I'm going to hand over to Lawrence in a second around actually locally what we do with our operational teams to ensure they're supported. But the concerns offered by the CQC were around senior leadership visibility. So we absolutely are ensuring that our operational managers and leadership teams are there for our staff, but the concern was around senior leadership. So to answer that point, we've got the leadership visits, but actually something else we're also doing, because again, your point around transparency throughout the organisation, is we have introduced a refreshed integrated quality report. And where we're moving to with that is to ensure that we have patient-to-board reporting up and down the organisation. Because actually, the board, the organisation at a senior level, is typically cited on challenges, performance, organisationally. And actually what we recognise is that there needs to be greater granularity and detail so we can share learning, so we can quickly and robustly pick up challenges and address those. So that's something we're working on. The IQR has been refreshed and we've already started that process. The last point then around demand management, we don't have our colleagues here who can provide further detail, and of course we can provide follow-up detail if helpful. The point I was making was around, it would be fantastic if we could plan in a way whereby we have sufficient capacity to meet the foreseen demand. But the commissioning factor, the attrition, etc., all those factors do add to that. So there are plans underway. We have introduced a new annual planning group to get on the front foot to look at actually how we're planning for the following financial year. That's co-chaired by two of our executive colleagues, the Executive Director for Planning and Business Development and our Chief Finance Officer. What I would say is, coming into this financial year, perhaps we were slightly behind timescales in planning for the new financial year. We're in a much better place this year compared to trusts, other trusts within the region. We are actually sharing some of our process that we've introduced, and we're in a much more positive position. And finally, we recognise that it's not always appropriate to send a physical resource to an incident, and we're seeing that more. So actually we're seeing that we are doubling up and duplicating on physical resources for incidents, and my point earlier was we need to look at what does the new or the refreshed care delivery operating model look like. And so that's, again, not to make an excuse, but it's just to offer assurance that we are looking also at actually what that delivery model needs to look like to more effectively and efficiently manage the demand and activity that we're seeing. I'll just pass over to Lawrence, if that's okay, Lawrence, just to provide further detail around the operational management support.
Yeah, sure. Thanks, Matt. So I'll try and give an element of reassurance around what we're doing locally in terms of staff welfare and that sort of thing. So the NHS staff survey nationally, last year, Medway OU was the #1 performing OU for staff welfare and for staff morale. So although, as an organisation, we've clearly got a lot to do, as an OU, locally, we're benchmarking quite well. Well, clearly there's more to do. Some of the things we've done locally is that we try and make sure we've got a senior manager, so either me or one of my deputies at both our sites, so at Medway or on the Isle of Sheppey. And we've also developed an automated welfare system that's been dread by staff, so when they attend something that's particularly traumatic, there's something called Interim that's available for them, which is a sort of trauma resource counselling piece of work. What I would say is probably the single biggest impact on staff welfare, certainly during winter pressures, is the improvement we've seen at Medway Hospital with handover, and that's been driven by our colleagues at Medway, and I know Jane will come on to that, and the engagement with us as well. So we've worked really closely to try and ensure we really share that risk, manage the risk in the community and manage the risk in the department down in ED at Medway. And we've seen a significant drop in what we call late sign-off, so the amount of times our crews are working beyond their shift. And Medway for November, December, and so far this year is the top performing trust in all 3 counties of our region. So handover under 15 minutes is nearly 60%, and 1.2% of ambulances in Medway having a 60-minute breach, which is literally fallen off a cliff compared to where we've been in my time in Medway in previous years. So I think there is lots going on. The other thing to mention is that, and you touched on it earlier, Matt, around statutory and mandatory training, something that fell by the wayside during COVID because of obvious reasons, but locally we're over 90%, and I'm hopeful we're going to reach 100% by the end of the year. So it's staff making sure they get that really important training. So it's lots going on locally, and I think absolutely more to do, but benchmarking quite well against certainly our colleagues in Kent and East Sussex.
Okay, thank you. Councillor Murray.
Yes, thank you. And thank you for the report. I'm going to start with some good news, actually. Yesterday I went along to the picket line in Medway, and I spent an hour there talking to the staff. They had fantastic public support. I think someone was tooting a horn every 20 seconds we measured. The lady who lived opposite came out with a tray of freshly baked carrot cakes for everybody. Other people were passing by and giving gifts. And actually, Lawrence, the staff there, because obviously I had seen this report and I was coming here today, did support what you say, that they did believe that their local managers were behind them and supported them, and they felt very well supported for the strike, actually. They felt that you understood the reasons that they felt they were forced to take industrial action, and that you were sympathetic to particularly some of the financial challenges. So, I asked about 25 people there. I asked lots of them very direct questions. They were happy to talk to me, and they were the answers that they gave. So something's going right somewhere. And I think that's a good thing. And it's pleasing to hear that in Medway anyway, things are going better. And I'm sure that that is attributable to some of the relationship building that's going on. On the point that has been made about communication, and as other colleagues have said, we've seen some of this disconnect between management and staff over a long period of time, and it is regrettable, and there has been a lot of turnover at the top. There's no question about that in the trust. But I think, you know, I'm taking your commitment to giving that feedback loop so that when you go on 100 listening sessions and whatever else you do, there is a proper mechanism for people to understand that they have been listened to and that there is a possibility anyway that things can change according to the things that they have said to you. And, you know, I felt a little bit like Councillor MacDonald with the kind of, you know, slimming world aspect of the well-being. You know, I can see it's part of a bigger picture. It's well known that when you do shift work, actually, it's quite hard to balance diet and your metabolism and all those kinds of things. And we want to make sure that people are being supported in a kindly way and that they feel that the things that are on offer are things that are, you know, don't blame them for anything that might have happened for them to get a bit out of condition, however many carrot cakes local people come along and give them. But in that list, I was really sad to see that there's a mechanism for post-suicide intervention, because almost having it there, and you know, at one level you can think, well, you're being realistic about what can happen, and this is a group of people who can experience pretty severe trauma. But even having it there kind of made me think there's an expectation that people probably might commit suicide, and I don't know how helpful a message that would necessarily be to the staff, and I'm interested in the background to that. On page 62, it talks about the current workforce plan under responsive care needs to expand to encompass recruitment and retention. You've said you're getting on with that, but you know, you've got people leaving at the other end. And I wonder if there's some work to do to try to prevent that, actually, that people feel as much as you've got a big recruitment campaign, you've also got an equally determined retention campaign. And obviously part of that will involve the offer of flexible working, different patterns of work, maybe the opportunity to do different things. And I feel optimistic about the Medway Make Ready Centre, because I think having things together, there's an opportunity there, isn't there, for people to perhaps move backwards, you know, not all the time, but maybe if their circumstances and the way that they're feeling about their work is changing, there might be an opportunity for them to move into something else in a different set of working conditions, rather than just think that they've got to leave. And if you can be open about that opportunity and people can see what each other are doing, I would be reasonably optimistic that that might yield you know, perhaps a bit less of an attrition. I do agree that you have to take COVID into account, actually. We're only really seeing now the difference that it made, and it's not just in the ambulance service, it's absolutely everywhere, right across the public services and actually in the private sector too. And I think we have to be honest about that and not get into a narrative where people are using it as an excuse. It's actually a realistic and professional way to look at the difference that it made and accept that it did make a difference and get away from this idea that, everyone's hiding behind COVID. It's actually still with us. So the idea that people are hiding behind the pandemic is a load of nonsense. It's still there. It's still challenging hospitals. It's still challenging people's attitude to their own health and the things that they do, mine as much as anybody. You know, it's only very recently I felt confident enough to do some of the things that I used to do. And actually, I change my professional working pattern as a result of the pandemic, and there's nothing unusual or special about me. Lots of people did it, and we're having to, as employers and employees, we're having to respond to that. So when when we're thinking about the disconnect between senior managers and the frontline workers, but both sides actually can learn to be quite proud of each other. I think the board do deserve some praise for the things that you've got right, and keeping going and actually managing to balance the finances across a huge geographical area is one of them, actually. That hasn't been said here, and it's not the case for every ambulance trust, so I do think that's a good thing. I wonder about getting staff representation on the boards. I know that people will get bored with governance and don't care about it, and I understand, in lots of ways why they don't, but actually making that offer might be another way to close that communication loop. So a few ideas, a few observations. I'm interested to hear what you've got coming back. And I think, from my experience yesterday, the trust wasn't seen as the villain of the piece, actually. It was the government. There's no question about that in my mind. By passers-by, by everybody on the picket line, and even by an Alsatian dog who was barking at a photo he was shown of Steve Barclay. So there it is. One final, more prosaic thing. On community first responders, I had an email actually very recently from a constituent in Gillingham who'd done the community first responder training, who was actually a perfect person to do it, an ex-policeman who's now working in fire service training. And after 100 days, had never been contacted by anybody, even though he'd made efforts to try and do this community falls teams training because he accepted that, that might be perhaps the best contribution he could make. And he decided he was fed up with it. Sent an email to give the equipment back and say what he felt. And the fastest reaction he had was somebody knocking on the door the next day to get the defibrillator back. And he was very disappointed in that. Now, that may be an isolated experience. I'm happy to pass on his contact details if somebody wants to get back to him, because I think he could be pulled back into that. But the Community Falls team is a good thing. Last but not least, something else that I was told on the picket line yesterday was that, apart from conditions of work and all the things that we've talked about, one of the things that had massively changed is people being called to a situation, and this is before they get to waiting outside the hospital, that they can't really do anything about. There was a chap there who'd been in for 7 years, and he said, 5 years ago, I didn't get called to people's houses where the biggest problem was that they were cold. And what can I do in those circumstances? Other than wrap them in a blanket, take them up to the hospital, give them a few hours respite from being cold and miserable, and take them back. And he felt, actually, that kind of thing and the high volume of calls were things that formerly, even in quite a short career, he hadn't had to deal with. And there's a lesson for us here and all of the partners, aren't there, to think about that, how we make primary care more effective, how we get people using the right service at the right time, because they've got confidence that the other services are going to help them. And I think that, that has materially and physically and professionally affected the job that you do. We've got to get the whole of the health landscape right, so that people don't just phone an ambulance because they think they can't do anything else. And that of all the comments I heard, that one marked me, actually, because I thought, well, it must be horrible in a job where you are, generally speaking, always a welcome sight. There's no question about that. It must be really professionally undermining to feel impotent that you can't do much. And, I've got to take that seriously as a local councillor, and so has everybody else, actually.
Thank you. So just to touch on the feedback from the picket lines, really heartening to hear that. So thank you for that feedback. We worked hard, really hard locally with staff side colleagues and the team leaders, and both me and both my deputies spent time on the picket lines yesterday. and at the strike before Christmas, because I think, you know, we have every sympathy in, you know, in terms of the state of the wider NHS and the NHS ambulance service across the country. You know, it's making nightly news almost, you know, because of the challenges we're all facing. So it's heartening to hear that staff locally at least feel that they're being supported in their right to take action. And the day largely went off, you know, quite well. We were able to provide a decent response. I was out in an ambulance, had to dust my stethoscope, and yeah, the day went as well as we could have hoped it to be, I think. You touched on the suicide intervention side of things, and I'll let Ray and Matt come in, but my understanding is that's something that's not sort of publicised in the trust. It's something that's a mechanism that's there that should the thing happen, it's a way we can learn from previous instances, whether that be our liaison with the family, whether it be, you know, there's a particular work element to it. My own personal view is that I think, you know, we've got an increasingly junior workforce, and I think even despite the fact that emergency service workers are at increased risk of suicide, sadly, thankfully the cases I've dealt with, you know, have not been sort of work related, but I think undoubtedly you can't do this job and not have an effect on you. It's, you know, the overruns, the stuff you're exposed to. So there's lots going on internally to address that sort of things. But my understanding is that is something that's a mechanism that's in place, but it's not shared with staff. The other bit you touched on was around attrition, and I think Matt's gone through the sort of statistics already. I guess what I would say is that our headcount stability locally is not the best, but it's also not the worst. Things we've got in our favour is we've worked really hard around something called the Joint Response Unit, which I think probably brought to this forum previously. This is almost, and it had really good publicity this year. It was on a TV series, and we won an award for it with Kent Police, and it's something that keeps our most experienced paramedics engaged and wanting to do something different. And you mentioned about the move to our new centre at Bredgar Road. That will open up another world of opportunities, because there'll be the ability for people to work in the 111 service and in our emergency operations centre as clinical supervisors. So I think the other bit is around our joint response unit. So working with our colleagues at Medway Community Healthcare, it's another string to a paramedic's bow, essentially, because they're a valuable commodity now. Lots of people are fighting for them, whether it's primary care, the hospital environment, the private sector. So it's a challenge to keep them engaged and wanting to work in a green uniform and do the full rotation of shifts and all the challenges that come with it. The last bit around, and the other bit I wanted to touch on was around our PPs, and you said about some of the calls going to people feel they're sort of, or clinicians feel that they're not able to have a meaningful intervention. I think, you know, that's part of our improvement journey in terms of understanding where we want to be as an organisation and actually what our role is, because we, you know, I think back to when I joined and trained as a paramedic, the role has changed so much, you know, so much more primary care and mental health exposure. One of the things we're looking to do in the very near future is take a crop of our most experienced Band 6 paramedics and utilise those in our PP hubs, so they can actually call patients back that might not require an emergency ambulance tipping up at their door, and interrogate those people. You know, to say interrogate sounds awful, but you know what I mean. Use software to do a triage before it gets to an ambulance disposition. And on the last point, I don't deal with CFR training, but my understanding is we've recruited someone very recently in North Kent to spearhead that, and I'll be more than happy to pick that up with them and give feedback on that. Yeah, of course, yeah.
Just one thing, Lawrence, I didn't say that's important for everybody. One of the really impressive things about yesterday was the fantastic support from the strikers for the people who had to go out to Category 1. They're coming in, they're supporting each other, waving each other off, wishing each other luck. People coming back from a Category 1, a Category 2 in some cases. Everyone's like, how did it go? Was everything okay? You know, so their commitment to keeping people safe actually was there as well.
Thank you.
Try not to duplicate, just a couple of points to clarify, Councillor Murray. Completely agree with the industrial action piece. We also absolutely made sure that we had full senior leadership visibility and presence throughout the organisation. We're also in a much better place with regards to relationships with our union representatives and staff. And that was demonstrated by the fact that we were one of the first ambulance trusts in the country to reach an agreement on derogation, and actually the approach to be taken. The agreement that was in place for prior to Christmas also continued throughout to yesterday's industrial action. So it demonstrated that actually we have good rapport, good working relationships with our union colleagues. And again, I was going to highlight, you've already done it for me, the positive encouragement and support for colleagues that were going out to offer that life and limb cover as part of those. Not going to add any more to the point around non-emergency calls still feeding into 999. Lawrence has covered that. All I will say is absolutely, this is part of our care delivery model review. And my point earlier around actually we need to now look at is sending a physical response to every incident the right thing to do. Evidence suggests it's not. We need to maximise and look at what we can do virtually via the hear and treat piece. I think just one thing to note is a key area of focus that we as an organisation we are committed to and we're currently working with partners on as a regional programme is urgent community response. So we have far too many individuals that become what we term, for want of a better term, long lice within the community, waiting hours on end for someone to pick them up, and actually they're coming to harm as a result. So we are doing some fantastic work, and Ray is leading on that with our urgent community response colleagues across the footprint. And within 2 out of the 4 ICS footprints that we cover, we've now got a single point of access for our clinicians. So they're not a whole list of numbers to try and work out who you can refer into. There's one single point of access, which then makes that referral much leaner, much more efficient. Excuse me, and we can optimise those for and support our clinicians. First point you made, Councillor, was around some perhaps greater assurance around our approach taken to culture, and we've had some really helpful and productive discussions around that. All I would say is, the key difference for me is we last time around had a CQC action plan that was a transactional plan that lasted for a couple of months to turn the organisation around. We now have an improvement journey that's made up of 4 programmes. It's been ongoing for 12 months. We've got a plan for it to continue for another 12 months, and there's about 40 different work streams. Each of the 4 programmes is co-led by an executive director. So every one of our executive directors is leading jointly on one of those programmes. So it just demonstrates the commitment. You mentioned staff representation on at the board and at subcommittees. We've started to explore that and ensure that, and we've taken that one step further. So what we're looking at for our quality governance groups and our board subcommittees is patient representation as well. So working with the likes of Health Watch, because actually ambulance services, in my experience, aren't always great at bringing in the service users that the service is impacting and affecting, because actually we provide an emergency response, but we still need to listen to those service users to understand experience of stroke care, of falls, frailty, etc. Lawrence is absolutely right around the post-suicide intervention we have in place. We don't actively promote it, but unfortunately we have seen an increase, or certainly a number of cases in recent years where actually we've needed that support. Evidence has demonstrated that being part of what we would refer to as the green family, staff actually are more impacted by the working environment, working conditions, because of that close rapport. As an example, if you are working with a crew colleague as part of a rota, you spend 12 hours a day with them 4 days a week, you can see that quite quickly actually our colleagues can be adversely affected by those type of events. So we absolutely and have recognised the benefit having utilised that, but we're not actively promoting it, but I think it's a good measure and mechanism to have in place. Perhaps where I'll just spend just a couple of minutes just to focus on the retention piece. So spoke about exit interviews earlier on, undertaking thematic analysis from the exit interviews, which has given us a greater understanding of why our people are exiting the organisation. We had a retention plan approved in November, and that was approved at our board as well. So what that plan looks at is becoming a fundamental component of the culture and leadership programme that we've signed up to as part of the NHSE Culture and Leadership Programme. Clearly, and we can share data if helpful, our greatest area of opportunity and focus needs to be 111 and EOC, so the contact centres. Lawrence touched on the headcount stability locally. For our contact centres, our annual rolling turnover is 40% for our contact centres, with a headcount stability of 70%. That's not sustainable, and there's something that we need to address there. What I would say is that actually contact centres are challenged nationally, but that's not an excuse, and we need to look at how we can address that. We have a retention plan, as I say, that has been outlined, particularly for our EOCs and 111 contact centres. And if we adhere to the plan, the view is, and the modelling demonstrates that we could get that annual rolling turnover down to 10%. So that's the expectation and the indicators that are coming through. Just for awareness, our field operations annual turnover rate is 8%. So it's considerably lower, but still, again, there are some sustainability concerns regarding that. I think the last point I would make around retention is it's not just around retention, because we need to get the top bit sorted as well. So recruitment selection. So what we're looking at as part of this plan is actually our recruitment process to ensure we have the right persons, and that's everything from skill set capability through to personal resilience components, etc., for those roles where we're seeing the highest turnover. So back to wellbeing support, how are we supporting those colleagues? Actually, we shouldn't be supporting colleagues when they become challenged within the organisation. We should be doing that from the outset, and that part of that is making sure that we are supporting the right persons in entering what is a complex and can be an extremely challenging working environment.
Thank you. Councillor Purdy.
Okay. Thank you for all that. I, like Councillor Murray, went along to be on the picket line with because the ambulance station is quite close to me, and I was very impressed with the way it was being run and organised. Those chaps need all our support, and I'm sure here this evening they've got it, because as we all know, the paramedics are the first people there, or the ambulance people, and they're always bright, always cheerful, and always trying to support people. So it's our turn to try and support them, and I'm sure we will do. But what impression I got was, yes, they do speak to management, but actually a lot of them felt that, yeah, it's fine, they talk to us, they ask us questions, but it stays in the in tray and doesn't go much further. And then you go and say, well, we done so-and-so and so-and-so. Well, oh, well, we're looking at it. And in the end, you get a bit fed up with people saying that to you, don't you? The same as you come along here and tell us all wonderful things, and we've been very impressed, and I certainly have been impressed with what you said this evening, but how much will this materialise, and how much do we really know we're out there supporting the people who are on the front line? And I think you have a great thank you to say to Medway Hospital for what they've done with turning the ambulance service round. I think that that's a brilliant job and proves that it can be done by working together.
I think just two comments there, Councillor. I think the first one would be that we absolutely recognise that, again, this is back to engagement, two-way dialogue, and we need to make sure that actually that happens from the point of contact with our staff members right the way up to board and back again. I've mentioned that we've sought external support to improve our communications and engagement mechanisms, which we're working through. The other piece that we're working through at the moment is we will be introducing a continuous improvement framework, and we have recruited a Deputy Director of Quality Improvement, and part of that is to enable change and change and initiatives to take place locally, informed by staff, for the staff and patients. So that framework will absolutely look to empower and create the space and opportunity for staff to have the ability to make those incremental changes and for their voices to be heard. Now, that framework hasn't even been finalised internally within the organisation, but that's certainly something I'm sure we can bring back and we can discuss with your colleagues here. So what I'm hopefully demonstrating is a commitment to the fact that we recognise that there has been a gap. We're communicating, we're not listening as effectively as we could be doing. Unfortunately, some of that has been stalled by the real focus on the full warning notices, but now we need to make sure that actually our focus is meaningful for our staff and for our patients.
So I can go back along and see them and join. Maybe I'll get carrot cake next time. We didn't get any cake. We did get lots of things. And I can say that you actually are prepared and you will be listening.
Absolutely.
And you won't let me down, will you?
Not at all.
Right, thank you. If I can ask a question on the suicide prevention group. You talk about them being recently formed, etc. Have you looked at other trusts that have groups for best practice, and because it's an extremely difficult area to get right. You can take the same circumstance and some people will want to talk, some people won't. I'm not always saying professional help is the way to go, but you do need to know what you're doing and where you're going. So can you answer?
I'm happy to start. Lawrence or Ray might want to offer some additional context, particularly locally. To be completely honest, Councillor, I think actually the focus on the post-suicidal intervention group is perhaps actually where we shouldn't be starting. Actually, we need to start well before that. So what we have in place, and I think it's referenced within the report, is we have a trauma risk management programme, and that's to pick up proactively, identify proactively early on those colleagues that actually are perhaps struggling or challenged with the demands of general work pressures or due to a specific traumatic incident that they've been exposed to occupationally. We've also supported those colleagues that have had additional stresses outside of the occupation through the Wellbeing Hub. We've mentioned the Wellbeing Hub this evening. We've expanded the support that's offered through the Wellbeing Hub as well. So actually there is therapy and counselling that is available through those hubs. It's actively being used, and actually we have seen some real value to the support that's offered through the Wellbeing Hub. In answer to your point around benchmarking against other ambulance trusts, actually what we've found is the greatest learning is actually from other arms elements of the public sector. So actually looking at what our police and fire colleagues do, looking at the mechanisms and approaches taken within the armed forces in particular, and an organisation that I know our colleagues in South Central Ambulance Service and others have been using and that we absolutely are now aligned to is Mind, which offers those additional supportive mechanisms and measures for those colleagues, particularly on the front line, but across the broader ambulance sector.
All right, thank you. Yep.
Can I just make one plea? I know I made it to Ray before in the past, and that sounds like we're ready to go, but we're not. We're really supportive of your team tonight. But the one thing I would say is about engagement, even with, like, we are your service users, because, well, touch wood, you don't have to use you, but you know, we are. But, you know, your newsletters, your communication would be really helpful. I know some people may get it, but some people may not be on your list. But some of that, not just from last March, more regular would keep us more engaged with you. But also, don't forget your voluntary sector. You know, other trusts really engage with their voluntary sector, and Lawrence would know, and Will and others would know, the voluntary sector did come out during the pandemic. They did come and feed a lot of the crews. They did come and do a lot of stuff. And they're always there. There are organisations that deal with suicide, organisations deal with counselling, that would more than likely happily give that free of charge. You know, so it's just about maybe to look at your engagement plan and engage with counsellors, because we are supporters of your team.
I think that's really, really helpful feedback. Thank you, Councillor. And I've made reference to the fact we recognise that we need to bring our patient and service user groups into what we're doing, into the improvement journey, but it's broader than that. So we will take an action to look at that in greater detail.
If I may, I could just come in on the back of that. We've had a number of forums recently where, you know, all partners, you know, voluntary sector and NHS and social have been involved in kind of conversations about how can we link in better together. I think culturally one of the challenges we have is traditionally we're probably looking for a clinical referral. So ambulance crew on scene, we tend to be thinking of clinical. We're actually, you know, we already know, and we've touched on it, the person who's cold, actually this is about a social concern. Actually, how do we link in with voluntary sectors who can come in and support meaningfully? So we are engaging with voluntary sector as a part of a bit of a system approach, and some of that's around public health management.
Right. No, thank you. Thank you. Councillor Purdy.
So we'd just like to say thank you for coming along, and we have given you a good grilling, haven't we? You can go off now. And I'd just like to say, I move the report, I move that we note the report and request a briefing paper on safeguarding arrangements at the Trust.
And also, Councillor Lammas asked for some more information, if that could be sent to all members, please.
Actually, Chair, if I may, do you want me to report within this forum the Category 4 mean now? Would that be helpful? We've got it, or
if you could send it to Michael, and Michael will share it with all of us, please.
You don't want to add to your work.
Thank you very much. Thank you. There will now be a short break for 5 minutes. Thank you. Thank you, members. That takes us on to agenda item 7, which is the update from Medway NHS Foundation Trust. We have Jane Black, who will introduce the report. And yes, your microphone is on.
I was testing.
And can you remember to keep it close, please? Thank you.
Thank you, Chair. And thank you for inviting me to come and talk through the report. It's the first time that I've been here, but thank you very much for inviting me. I hope you've had an opportunity to read it, and I'll take it that you've read it. I will highlight a number of things, and I'll try and pull out some of the things that I've heard this afternoon, this evening. Certainly, the Medway MFT is definitely on a continuous improvement journey, and I think you can see some of that in the report. I won't go over all the ambulance data. You can see it in the report around emergency care. But it is one of the things that I'm really proud of with the organisation. Working with the clinicians, they have put in a new model of care, which they have been working on probably on the last sort of 6 months or so, because it was not acceptable that we could not offload ambulances, and that's well known within the organisation. And therefore, you can see the impact. And I do have to just say, I have to call out, certainly over the last 3 to 4 weeks, it is unprecedented what we've seen. And it's right across the board. But certainly I've been in the health service 40 years this year, and I've never seen a winter like this. But actually, when you look at the ambulance data and you look at the care data that we look at, we have tried to maintain the standards that we wanted to do. So, and I think actually when you look as you go into January as well, you can see, despite the challenges that we've had, we've still maintained really good times around offloading at 15 minutes, at 30 minutes and at 60. So all credit to both my organisation and CCAM. But it is wider than that. It is a system response because I can't do it on our own. So it's really important. Just around emergency care, I just wanted to give you some sort of idea. The ambulance piece is just one part of the work that we are doing around our improvement. And some of the big things, picking up on the discharge piece that was mentioned earlier on right at the beginning about the pathways. We are fortunate that I think we've got a really good health and care partnership here. And actually we are working together, and actually Jackie probably sees me more than she wants to. But certainly we've started to work really well together, I think, looking at what the challenges are and how we can approach those. Just to give you a flavour around the medically fit numbers that we see at the moment. So these are patients that are medically fit to go out the door, but are waiting for something. And that goes across pathway 0 to 3. So 0 is in my control, in our control. And pathway 1 is packages of care, 2 is community, and 3 is around care homes and residential homes, etc. and housing and things like that. Today I had 156 people waiting. So when you put that into context, that is a large amount of people. Now some of those people will go out the door, but if I'm really honest, probably 60 of those will go out. Yeah, so I've still got quite a lot of patients that are waiting more than 24, 48 and quite long time for whatever care they next need. But I just wanted to put that into context because certainly over this last Christmas period, I've had to, we, the organisation, has had to open up a number of escalation beds. And I just wanted to give you a little bit of context around that. So as we went into November, I had 65 additional beds above my capacity that I am funded for. And that's a way of us planning forward. We work that through. Actually, that's a combination of an additional ward and some additional areas. But as we went into Christmas, and as I said, this was a Christmas and New Year like I've never seen. Actually, we didn't get people being discharged home. We had seen a slight increase in both COVID and flu, and that was taking its toll. But also, we didn't have the outflow, if you like, to be able to discharge patients out. And actually, where I am today, I've got 103 escalation beds open. And what I had to do was open another ward. I had to go into our gym area. I've had to put additional beds into wards. And we've had to use our assessment units, which are essential to be able to keep going on a day-to-day basis. But we have had to use bedded areas. So when you talk about what the impact has been, and CCAM has certainly felt a lot of that, we certainly have as well. I'm not going to sit here and bleat on about how that is. Actually, across nationally, and particularly across Kent, it's been really, really challenging. But the one thing I do know is that certainly all organisations have been trying to support and help us try to resolve some of that. What I'm pleased to say is, and throughout that time, we went into business continuity, and actually I did have to call a critical incident because of where we were, because of staffing and being able to place patients safely. And that's the one thing I will say to you is whatever we have done, it has been clinically reviewed, and it is reviewed on twice, 3 times a day to make sure that we are doing something safe. I think the last bit, and you would have seen it on the television, certainly a lot of other hospitals, is the fact that we've had to care for patients in the corridor. That is not what we want to do. And actually, I can say today, for the first time in probably about a month, we have actually improved, and we went right down to 1 person in the corridor. But that was our normal way of working and being able to offload ambulances. So we actually came out of business continuity, and we are now on Opal 4, which is part of our escalation. But that is all credit, as I say, not only to my organisation who have worked in a way that I've never seen. Actually, that is a system response. So you can see some of that under the emergency care. Despite that, just really quickly, we have an obligation not just to do emergency care, but we also treat patients electively. You will see from the paper some of the challenges that we had, and it is post-COVID, a lot of it. We were doing really well around treating patients over 52 weeks, and our drive through our continuous improvement strategy, which is patient first, which for me is a continuous improvement. It's not a programme of work for 3 months or a year. It actually is something that we will continue to do and how we do business around here. So, but actually what you see is actually we were driving towards 40 weeks because the size of our waiting list post-COVID. And actually that's what we continue to do. And you can see that ENT, because of the nature of the work that they did in COVID, actually is probably the biggest contributor to the size of the waiting list. But they are working exceptionally hard to try and do that, despite the fact that we are using our beds in a very different way at the moment. I think our success story really is, I'm very clear, and so is my clinical colleagues and exec colleagues, that cancer is really important as much as anything else. And you would have seen we were 9th in the country, and we have maintained a lot of that right across the board in terms of our standards. And that's not easy when you've got the challenges to try and balance everything around it. Just in terms of workforce, there is a huge amount of work going on at the moment, particularly in some really challenged areas. Nursing has done really well and has looked at sort of a number of options around local. You know, we want to entice people into our organisation that live locally. We've been working with schools and colleges to make sure that we can grow our own, if you like. Nationally and international nurses. And our task really over the next sort of year or so is to really look at that retention and how we keep those nurses, because we're very clear that, you know, where we do get turnover, it's often after a year of being with us. So we're doing work to understand what that actually is all about and what we can do to improve that. You've got a piece which you did ask for around finance. You can see, actually, we were doing okay up until about month 5 and month 6. And actually, we've reported a deficit in month 8, and that is all related, if I'm really honest, to the escalation capacity that we have got open. And that relates to the number of additional beds we have, but also the additional staff that we have to employ and put in. So you can see it in medical staff. You can see it in the additional clinical supplies that we're using. And so what we are doing is working with our clinicians at the moment to find a different way of working so that we can manage the extra capacity. But actually, going forward, I was talking to some of my operational colleagues today. We will start to reflect on winter and how that's been and our planning and everything that we've done. We will start doing that now so we can start building that into our business planning so that we've got that over the next few months. So I think that's really important. I'll probably leave it there, and I'm sure you've got questions that I'd better answer.
Thank you. I would like to say 2 of my family members were treated in the corridor, and although they did not like being in the corridor, they got all the treatment they needed and they were well looked after. That's more of a comment than a question. So.
I think the big thing for me is actually, I probably should have done this at the beginning, is to apologise that we've actually had to do that. But I think the one thing for us is about making sure that any person that is in our care, we look after them safely. But, you know, it's a real heartfelt apology, but it was an option that we've just had to manage through.
Again, in my case, the treatment was, well, what you would expect. So, yes.
Good.
Councillor Lannis.
Thank you, Chair. I really rate you. I think you're a great leader. My question is about the ambulance handovers. So I love the fact that in a year, November 21-22, you went from one of the worst performers for handovers to one of the best. Could you just break down to me how you did that? And what I'm interested to find out is that, was there a significant additional financial resource put in? Or was it just a change in management approach? Because the point I was trying to make in the previous session is that it's all very well and good always talking about more money, more money, more money. But actually, the biggest changes can come with a change in management approach. And I think this is one of the best examples of that I've ever seen. I'd be very interested in your views on that point. Thank you.
Thank you for that. I'd probably invite you. I know my colleagues at the end there have already been down to see us, but if you ever want to come and see it. Actually, this is about not having loads of additional resource. I think one of the biggest things for me was around the clinical leadership that was in ED, recognising that again we cannot tolerate the fact that we can't offload. So what can we do differently? It came from them, and my job and my executive jobs is to make sure that we support that. One of the things was just give it a go. And part of what Patient First is all about is about, you know, PDSA, try it, see if it works. What have you know, for us, what have we got to lose? Because actually we weren't in a great place and we weren't doing right by our patients. So actually the credit goes to the clinical team. And that's just phase 1. Phase 2 is coming soon. And throughout even the challenges we've had over the last couple of months, they've actually maintained that way of working, so all to their credit. So, and they've learnt a lot. I think, I spoke to one of the leaders today, the nursing leader, and he's already on phase 2.
Thank you very much. Councillor Murray.
Yes, thank you for the report, Jane. And look, congratulations on holding on and doing all the things that you've done. Because actually, I think the ambulance handovers is a really fantastic result and something to be very proud of, as indeed the amount of nurse recruitment you've managed to do. Well, when you first came, you were very big on Patient First, and I'm pleased to hear that you've stuck with that, and you've given an example of where it worked. And obviously, with hospital in this huge escalation, it probably is difficult for people to do what you described to me, that is, get together in teams and think about their autonomy to improve things. But I just wondered if people have managed to continue to do that, and if the staff are feeling that their ideas and the autonomy that you hope to give them to change things was actually working. That's one question. I note that there's £18 billion of unspent COVID funds knocking about in NHS reserves. And various people have had various ideas about what ought to be done with that money. Well, you know, with one idea being, well, use it to meet the pay claim and move on. But I wonder, is Medway in? You know, have you got unspent COVID reserves? And if you have, are there plans to use them? Because I think it is possible that they'll have to be given back quite soon if that hasn't happened. That's the question. I'd like to know your view on what appears to be, we've had a 9% rise in excess deaths, haven't we, across the country, and that can be attributed to lots of things, but one of the things it's being attributed to is the fact that people have had to wait a long time to be seen in the emergency department. It's actually difficult to find local information. You can get a lot of headlines, but I've not been successful in finding any local information, so I wonder if you had a view on that, not necessarily any statistics. It might be good to get them, but you know, it's the kind of information that I think impacts on staff morale, isn't it? If they think they've been in a situation where more people have died through circumstances beyond their control than otherwise would have done, that's a really tough call. I've just had a look at the depreciation budget here, and obviously the hospital's got a lot of, you know, there was a huge backlog of repairs. I'm assuming it's still there. I know you've managed to do things like with the lifts and other things. Yeah. I'm aware the heating system is wasteful and old, and you've got more than one, and that is, I'm afraid, the inevitability about having a building that's got now different parts of it that are different ages. But I wonder if in your mind, having a new hospital is looking like the cheaper option, and how far we can go to that. I mean, under the last Labour government, there was a plan to go out across the lines. I'm sure you've seen that, to move the hospital in 4 sections. That obviously was abandoned, but I don't think the reasons for that plan being there have gone away, have they? If anything, they've escalated with the level of depreciation. So with thanks and you know, very genuine good wishes, that's the end of my questions. Suffice to say that I assume you have still got too many people turning up at the emergency department who don't need to be there. And as I said to the ambulance service, I'm very conscious that we've got a part to play with all of the allied professionals in making sure that doesn't happen, and trying to get the community services in a shape where people feel confident that they'll get the treatment they need without rocking up to you.
Thank you. Just around patient first then, so we've used it actually. That's what I say, it's got to become part of our DNA, and we are rolling that out across the organisation. So for people that don't understand quite what it is a set of tools for them to use, but this is a culture and practice, this is a way of being. And actually it's about how we can drive change, but you know, it's from people, I don't like saying it like this, but you know, people on the ground, it's from them that you actually get the biggest change. And one of the biggest things you can see actually is if you go onto one of the first pilot wards that we've used Patient First on, when you go to their huddle and you see them using the methodology to improve patient care, even in challenging times, I think it's really inspirational. And if anyone comes to come and see that, I'd take you down there to those. It's really inspiring. But actually, as I said, you know, today is a better day for us, although we're not out of the woods and we've still got a lot of escalation open. Actually, we've done that through driving through our patient first methodology. And that's about using red to green, about discharge, working together with our system colleagues, and that's a different way of working. And actually, from Monday, when I looked at it, to today, it's a different place. but it's a different way of working. The COVID funding, no, we haven't got unspent. If I had, I'd certainly go and use it. But no, it's not. And actually over the years, over last year, this year and going forward, we will have that COVID funding reduced. So we have to take that into account. And to some extent, you can understand that because we're living with COVID now. So whilst even if I've got, you know, we've had up to about 40 people in with COVID. Before that would have been very different. Now we manage it in a very different way. But the COVID funding, no, if I've got some, I would have spent it. The access deaths, I think you're absolutely right. Just to give you some assurance, anybody that's in a place that we wouldn't normally put them, but particularly in the corridor, harm reviews are done around those patients. And certainly we've put in other measures prior to this real challenging time. Is around if anyone waits over 12 hours in our ED, we will do a harm review so that we really understand if that's had an impact. I think on the staff themselves, I think you're right, staff morale around having that cohort of patients, especially in ED. And we're really trying to support them. I think the biggest thing I've seen over the last 4 weeks is the response from the organisation, and certainly talking to ED, when we've had up to 28 people in that corridor, you know, there's organisation have come down, they've supported, and it's been corporate nursing, it's been other non-clinical people that will go and talk to people, they will give them a cup of tea, they will do things. So, and I think ED has found that helpful, but we do need to look after them, but we also need to look after those other staff that have been looking after all the other patients that we've got as well. So we're very clear about our well-being piece and what we can offer, and I'm trying to hear what the staff want from it themselves. Is it enough, or what else do they want? So I think we do a lot, but we, you know, if we can do more, we will. The repair of the estates, you're right, it's an interesting estate, isn't it? We have got a programme of work, and in between Christmas and New Year, we did expedite the fact that we were refurbing a ward, and we had to open it, but it was completed, but we did accelerate it, and thank you to the contractors for doing that. But actually, that's part of our programme, Keats Ward. If you go into it now, it's like a different place. Which is great, but we need to continue to do that. You're right, we do need to look at, ideally it would be great if we had a new hospital, but that's not going to come online in this immediate time, and we do need to find other solutions, particularly to protect our elective patients, because we are emergency driven. The volume of work that we do is very high around emergency, and because of the nature of the work, it will take precedence sometimes. As I say, we do protect urgent and cancer patients, but we still have an obligation to our patients to provide an elective service. So we need to find other ways of doing that, and working perhaps with the council is one of those ways of us doing it. And I've put people shouldn't be there, but I can't remember what the question was.
Turning up at A&E if they really would be better trying to see someone in the community within primary care.
So big pieces of work. Part of, we're working with the national GIRFT team, and have been, and the work that I've talked about around emergency care and ambulance handovers has been through that piece of work. It's called the Harris Project. Actually, phase 2, which we're just about to do and go into, is about how can we work in terms of our community, and we have got a lot of data about where patients come, why they come, and what alternatives can we provide. So actually we're working very closely with CCAM, but actually that piece of work is quite exciting in the fact that we can really work together and try and find some alternative solutions.
Thank you. Councillor MacDonald.
Thank you, Jane. You wouldn't believe it, but I think even in your introduction, you answered a lot of my questions. So either Glynis had briefed you really well, or something's gone on here. But because you've answered me, but I'm going to touch on a few anyway. The retention part of your staff is really good. You know, your report is really good. It's been a long time where I've actually read a report and thought, one, and I'm not meaning it with your past executives, but one, it's really believable because I can see the work you're doing. But it's really positive, especially coming out the COVID part. So well done for all of that. But the retention part is a concern for me, and I'm wondering what work you're doing when you're looking at housing costs for your nurses, because they can't afford the rents. You know, you've got a food bank operating up in the hospital, which is a real shame. It's good for the staff, but it's a real shame that we're in that emphasis of having a food bank. And with our other hats I wear, we've had staff come to me in my other jobs that are using our food banks. So when you've got them challenges about retention and our rent costs and housing costs are going up, what are we doing? Is there anything we can do about that? So that's the one question. Yeah. The other one is about the critical care incident. I think, you know, it's a real thing for you to have to make that decision, isn't it? And you have to do it. And I understand afterwards as well, though, you were still putting out on messaging, which is good on your messaging about only those with life-threatening illnesses, please come. The issue I suppose you have is, and you did touch on it just now, is the challenge you have with our GPs, because I know GP surgeries in Gillingham that are 4, 5, 6 week waits for appointments now. So if you're going through, you're worried about, you know, I know we all say children should go anyway, or our pharmacists can help a child with some of the stuff that's coming out now, but people will end up with you if they're waiting 3 or 4 days for a 111 call to come back. They're going to end up in your A&E. So I suppose you've given me reassurance. I mean, you can never reassure whether you're going to have another critical incident, but hopefully you've passed that. But all the time people are piling in, like Councillor Murray said, it's going to cause you a problem. So only think about that would be really helpful. The elective surgery, I understand. We didn't get the number on the ones that had the 52-week breaches, but I'm not really over concerned, but you did already say that there was, you know, you had some of those. It's just about some reassurance about getting a grip on that now, because we weren't always hitting that target before the pandemic either. So it's about, you have sort of said you're getting on it and it's a continuous improvement, but it's about those waiting a long time to have their surgery, and that, you know, sometimes if you've got an illness, you worry about when you're going, you know, some of them really think they've got to have it now, otherwise it's going to get worse, and there is that concern. I was going to ask you about the pathways, you've answered that. One of the questions I was going to ask is about, you would have known, and actually similar years of service, I think, you hear Pat Cullen on the TV yesterday from the RCN saying that the morale and the crisis, and I've used crisis a lot tonight, and it's not, there is a reason for it, because you've just said this is one of the winters you've never seen before in many years. She's saying that nurses are feeling that the morale is quite low, but nurses are feeling that this is more of a crisis than it was during COVID at this moment in time. Would you agree in that, is my question. And the last one, which is a nicer one, you did mention about visits. That's really refreshing. The hospital is every councillor here, it's our hospital. And I know, because I'm a Gillingham South councillor, so the hospital's in Gillingham and others would know, it's always about parking, always about residents talking about us, about the hospital, problems with the hospital. We did have good engagement. I know you've been busy, but we had really good engagement before, and actually I felt sometimes we were helpful with the executive as well. So those visits for councillors, those visits for local councillors as well would be really helpful to re-engage, because, again, like I said to CCAM, we're nothing but supportive, and the more we know about your pressures, the better it is for us to help you. So that's my questions.
Well, if I pick up with that one, I think part of it, you know, because of COVID, we had to restrict right down. So, you know, it's difficult, but we are now encouraging people to come and see. We've got nothing to hide. It's important that you understand how we're functioning, but also what you can see and how it is. So, yeah, by any means, you know, let's work that through. I think you asked about crisis and the morale. I think actually, you know, people are extremely tired. And it's been unforgiving, I think, not just on these 4 weeks, but for this last year. It's been really tough for them, if not before, because COVID was very different. I wouldn't probably call it a crisis, but when we talked with staff, you know, and I worked all the way through, I was on site, not here, but I was elsewhere. I was in every day around COVID. It was very different. It's a different tension. It's because we didn't know what we were dealing with, and it was chopping and changing all the time. This is slightly different in the fact that now everything's opened back up, and we're having to balance everything now, and that is really tough, you know, trying to do that. So there is something about how we try and manage that going forward, because we've got to respond in a different way, because this is different. It's different from pre-COVID. I think, you know, it's really difficult when you keep asking people to do more and more. But I think one of the things I think from myself is that it's working with them to find the right way to do it, because then they can feel part of the decision making, because it's nothing worse than having one of me coming along saying you've got to do it like that, when actually they're the ones that are dealing with it every day. And they will have some answers that, you know, I wouldn't have thought of, or anyone else. So it's important to work with them. We haven't got it completely right around morale, I think, and picking up on your retention thing, I think, you know, we've got a lot of work to do in Medway. But I think we're on the right path, and that retention piece is really important. I want people to feel like, you know, we are a family. You know, it sounds really weird when you say it, but it's important. You know, it's important to the local community. It's at the heart of the community, isn't it? So people who come to work for us need to feel like they're part of it. And I think that's really important. So that retention bit, I think we need to do more, actually. Yeah, heartbreaking when we had to talk about how do we put a food bank in. And we were very conscious about people's privacy and dignity around that. So we've tried to do it in the best way that we can without going, there's a food bank over there, everyone, so go and have a look at that. The housing costs and thing, I think you make a good point, and I think perhaps actually we need to do more around that. You know, there is work ongoing, but maybe we need to look at that, because I think this is totally different, isn't it? The critical incident, you're right, people will come regardless of, you know, we will, you know, to call a critical incident isn't easy, but you just get to a point. We shouldn't sit in it for ages. It's a way of correcting where we are at that moment in time. But you're right. I think, as I said, I think we've got good relationships in the Health and Care Partnership. That's where we need to be working. Medway's at the table. It's important we're there so that we can contribute to that, because actually the old model of GP does this, we do that, actually we've got to think differently. We've got to come together and we've got to work in a different way. So if I can help them in a different way, that's what we need to do. But you're right, they see those lights on all the time and everyone just comes towards us. So I think we have to accept some of that, but we can work in a different way. The elective surgery bit, it's elective. When I say elective, I suppose I need to define what I mean. Elective means both outpatients and obviously surgery. Actually, our biggest weights at this moment in time sit with outpatients. And it is in 4 specialties. And we are doing the work around that. And that's because, you know, people weren't seen for a very long time. And so they've built those lists. Some of that might convert into elective, some of it will. But predominantly, most of that is sitting in 4 specialties. And so we are doing work with our clinical colleagues to see what we can do. We have outsourced things. And we're trying to make sure we are as efficient and as productive as we possibly can be. I think I've done everything.
Thank you. Councillor Turpin.
Thank you, Chair, and thank you, Jane, for your report and being here this evening. Just had one question. In 3.2, you mentioned this patient-initiated follow-up pathway. So I was just sort of interested to know what that sort of actually looks like and how sort of has that started, or I think it says implementing, yeah. And does that actually work? What's the sort of feedback from patients? Because it makes sort of sense to me actually to, rather than having, you know, an actual appointment, you know, that's booked, patients sometimes think, well, I don't really need it, but I'll go because I feel like I'm letting someone down if I don't turn up,
or don't
even
go.
though you don't need it, or yeah. So it certainly makes sense, but sort of my experience sort of in different departments of Medway Hospital and also other hospitals is that contact of getting in can really vary. So even within the hospital itself, some departments you seem to be able to get hold of quite easily and the secretaries come back to you and everything. Other departments you think, gosh, I've got no hope at all of ever getting through to anyone. So I just wanted to, and sometimes I think the clinicians don't tend to always realise that. You know, I've gone into appointments and they sort of say, oh, any problems, just come back to me. And you kind of sit there thinking, but how? You know, so I just wanted to know sort of in practice how that's actually working?
So it's a national initiative, and we started it last year, and we will grow that patient follow-up initiative, if you like. But actually, it takes time to embed something like that, and you're absolutely right. We need to have the processes, and the patients need to feel safe that actually they're not going to get an appointment, but actually we have got a mechanism to come back in. So we're rolling that out across the specialties, and I think that's important that we do that. But also it's with the clinicians as well, because they have to let go, which is also different. And we have to work with both understanding what the patient wants, but also how we work with the clinicians. So it is rolling out across the specialties. It is about making sure we've got a safety net for patients so that no one falls through the net, if you like. But it's probably the right thing to do. There was a lot of appointments that probably didn't need to happen. But that's changing practice, and that's clinical practice. So it takes a while to work that through and be able to give you more information around that and how we're getting on with it over the coming sort of 6 months to a year.
Thank you. Councillor Purdy.
Thank you, Chair. I'd just like to say thank you, Jane, and I do recommend that all members go and have a look around the hospital, because it was lovely to see how they're working together. Jane isn't the chief exec or whatever. Jane was one of those, and they were willing to please and help her. And the most memorable thing for me, Jane, was when I stopped and spoke to some people and their feedback. But one lady stopped me in the street and she said, "Can I say thank you for stopping to talk to my brother?" She said he died 2 days later. She said, "And I appreciate that. But it was you giving us the opportunity to go round and be able to speak to some of these people that made that possible. And you did feel a connection with them. So my thanks for everything that you've done. And I think that we should be very happy and grateful that we have had somebody at long last that has taken on Medway Hospital and is determined to make it work, because it is a partnership. It's all of us that are responsible for it, because it is ours. So thank you. Thank you for coming this evening. And we note the report.
Thank you very much.
Thank you.
I've now got to go and rescue my coo. My coo is waiting for me, so I need to go and see him.
Right. Is that agreed? Right. Thank you. Thank you very much, Jane. And Glenys, sitting there quietly. Yes. Right, thank you, members. That takes us on to agenda item 8, Kent to Medway Elective Orthopaedic Unit. I'm sorry I started reading that out. Rachel, over to you.
Thank you very much. I'm going to assume the paper's read and try and canter through the main principles fairly quickly and then leave some time for questions. So it actually was really nicely built on what Jane's just been talking with us about, which is the backlog of elective care. And orthopaedics, those of you that have sat around this committee for a long time will know that orthopaedics in this county, but nationally too, is the biggest contributor.
Sorry, can I interrupt you? Because I've only just read Michael's notes.
Oh.
Before I ask Rachel to introduce her report, do members have any questions on the cover report, which deals with the process around whether these proposals constitute a substantial variation or not? No? Is that everybody fine? Sorry about that. I really should read my brief, shouldn't I? Over to you. Thank you.
No problem. No, thank you. Sorry. So I'll essentially what this is a way that there's a national ask for the country to get to 130%, i.e. a 30% increase. It's a roundabout way of asking us to do at least 30% more elective activity over the next 3 years. that doesn't just reflect the backlogs that built up during COVID when we had to stop quite a lot of elective activity. It actually reflects what was the case before COVID, which is we were struggling with long waiting lists in some specialties, and COVID's just compounded that. So it's not just a COVID problem, but where we're left with, it is a sort of and the balance that you'll see in the paper, the balance between trying to cope with everything that Jane and a Maidstone and Tunbridge Wells A&E activity is no different. We're all trying to balance, and where we've got elective theatres and beds on acute hospital sites that are managing A&E, it sometimes has to give, and it's the national thinking, no surprise after COVID, is to try and do what we can to separate some of those things out as a future strategy as we go forward. So what this is a new build on the Maidstone Hospital site, and that's mainly because we've got the space and the land, and obviously we'll all know that lots of other of our sites are either PFIs or private finance initiatives, or they're massively constrained for space. But 3 new theatres, and it's in a really new model. It's the layman's language for it is a barn, and we're moving away from that in the description, but it's open plan. There are 3 operating tables in a massive open plan space so that surgeons and teams can work alongside each other, help each other, get information, support. And actually it's been proven in Europe to be really very, very efficient and effective way to work. Other places in this country do have them. We're not the first, you'll be glad to know. So the idea is that it will be built this year. It will be providing capacity for Kent and Medway, and it will be by choice and working with other hospitals. So nothing is changing at Medway Hospital in terms of orthopaedic capacity. I want to be really clear. If anything, they're going to want to increase theirs as much as they can. And we've got such a big backlog and such a high demand that we will need them. We will all need to do that in our own right. But the idea of this is that it's new and additional capacity in the system to try and take patients through more quickly. And just to give a flavour, Medway have got patients waiting over 12 months, but East Kent and Dartford have got patients waiting over 18 months for this surgery. In Maidstone, we're at about 40 weeks, so it's just under the year, but it's none of that. None of that is great if you're a patient waiting for your orthopaedic surgery. So I'm going to stop, Chair, and answer some questions I think would probably be the better use of the time.
If I can ask just one question in what you've just said, and I know it's obvious because surgeons, doctors would be well aware of cross-contamination. 3 patients, 3 surgeries going on at once. Can you put our minds at ease about that?
I can, because orthopaedic surgery in particular has got to have very significantly different airflow handling, and so when I talk about they're not close together. It's a big building, so the space between the units, you can close it off. There is a way to compartmentalise it if you've got a patient, for example, with an infection. Although we tend not to do elective surgery. This isn't patients for hip fractures and things like that. It is purely patients who will come onto the unit, 14 inpatient beds and 10 day case beds as part of the facility. But I can absolutely assure you about all the infection prevention control measures and the airflow handling units that are legally required to make sure it is safe.
Thank you. Councillor Murray.
Yes, thank you, Rachel, and thanks for the comprehensive chat we had at the pre-agenda about this. And I think from the Labour Group's point of view, whilst it is a big change, I think we're happy to say that it isn't a substantial variation, rather it's an extension of something that is already going on and needs to happen. But I would reiterate the concern, and I think this was a cross-party concern, wasn't it? What we don't want to happen is that this becomes a new facility that everybody who's working at Medway want to go and work at, and then we end up in a worse position at a point when we know that Medway want to expand their orthopaedic electives than we are now. Now, you know, in the report, you say you're going to support retention at the other centres, which I guess sort of talks to that, doesn't it? But you know, it's a tricky one, isn't it? You can't really prevent people from applying for a new job. You could incentivise their retention, I suppose, but that would mean that the other trusts would have to have the money to do that and be prepared to do it. So, you know, to me, that is a fear. especially given, from Medway's point of view, as we've just heard from Jane, people are working in outdated facilities.
No, it's a really very, very good point, and it's one that you'll know that I'm really well aware of, and it's really tricky, isn't it, because we want to recruit new people, but you're right, this is going to be a beautiful facility, and to be honest, very many of our theatres at Dartford in East Kent and at Maidstone are not going to be the nice, new, shiny, amazing environment that this will be. So it's a risk for every organisation, including the one I work for. So there's 2 or 3 things. One is actually, why wouldn't we work together, which we are doing, and as Jane alluded, to offer rotations from anywhere. Any staff that want to come and work as part of the new unit, as part of their current job, absolutely, we've got to. It would be wrong to bring a whole new workforce in or pinch from people, because it just... The whole point of this is to help the patients that are waiting and not, therefore, to reduce capacity in East Kent, say, to staff this, because it defeats the point if we do that. The other thing, so there's lots and lots of innovative ideas about staff passports, which we did generate during COVID. We managed to get over that hurdle of staff working for different organisations and the governance that there's always been a barrier. We did manage, COVID helped us to overcome those barriers. So we're going to look at rotations of staff and recruiting staff that would have a permanent base in one of our hospitals, but would go and work at the unit as part of a job rather than it being the job. The other thing we're doing is we're going out to overseas recruitment, so we're trying to genuinely bring new people into orthopaedic services across the county to try and enable that to happen. So we are, all the 4 acute providers in the county are working on the model of how we're going to do this. This is not a Maidstone and Tunbridge Wells going out to recruit and let's see what happens. That's not the model. But you're right, we need to bring the headcount up and then offer our current staff an opportunity to work through the unit should they wish to. And some will and some won't. But I think as long as people feel they've got the opportunity and they're making a positive choice one way or the other, but getting the numbers of people we need is probably going to be the challenge. So I'm completely cognizant of it and working with all of the other providers to make sure that we try and design it together.
Okay, thank you very much. There are no other members. Leanne, you wanted to come in?
Thanks, Rachel. I haven't got any questions about what you've said about the orthopaedic unit, etc., etc. My major concern is the timeline on 119. The Medway didn't know about this until the 11th hour, and I have asked that that doesn't happen. I know that you're in a new role, and I'd just like to reiterate that point and encourage you to remember Medway right from the beginning, because I really don't want to see a report prefaced by a report asking members to consider a substantial variation. It's not really the way to do business, but, I stumbled across this, and if I hadn't stumbled across it, we would have been in a very difficult position, and so would you have. So just a reminder, and I know, Rachel, in your new post, I'm sure you, from your past experience with Medway, will grip that and make sure it doesn't happen again. Thank
Leanne,
you.
so my very sincere apologies, but that's exactly what's happened. I've started in post and actually thought, oh my goodness, what? Oh no, we can't. So that's the reason I'm here and had to push it on the agenda. So at the minute that I realised and thank you so much for accommodating it at this, because it was quite short notice. I didn't want to get out for recruitment. I didn't want for that to happen and you not be aware. But I can give you my absolute assurance that we won't be doing anything like that again without coming to Medway, and I am very, very sorry that it's so late, and it's a year in the making to do, but you're right, we've known about it for several months, so it's not something new in that sense, and I'm really sorry that it's taken me so long to come, and I'll just assure you that won't happen again.
Thank you. It won't happen again until the next report we've got tonight, but that's not all in your right. So,
I don't think that's my fault.
So by members' comments, there's a couple of possible recommendations. I assume we are going to, the proposal does not constitute substantial variation on development in the provision of health services in Medway. Do all members agree with that one? And then Councillor Purdy will put that formally. Councillor Purdy. Sorry.
Yes, I mean, I think, you know, absolutely, and I'm pleased that Leanne has, you know, put your stamp upon this, and we did say it, didn't we, Rachel, when we saw you? And, you know, without bringing up the past, not the first time that something like this has happened, I'm afraid, but on this occasion, and because it's like a national initiative, we haven't really got a choice, is the situation in terms of the substantial variation. But I think if we can just work into the recommendations that the point that Rachel's made and the point that Leanne's made, not just that we are kept informed, but that we really do see in our expectation that we're not going to suffer a recruitment attrition as a result of this happening. Now, I don't know how you know...
If we leave that for Michael to work out, yes.
And also for us to be involved at a very early stage.
And can we say what a good national initiative it is? Thank you for reminding me.
Oh, you know.
Right. Do you want...
I'm not going to repeat it because my brain won't take it. Michael's got it all down, so you'll be okay, Rachel, won't you, with that? Just to say thank you, and I know you've made a special effort.
Michael's going to summarise.
Oh, go on.
So I think the decision the committee are looking to make is that you don't consider this to be a substantial variation. You expect the provider to make sure that there isn't any recruitment attrition as a result of the proposal, to be kept informed of progress and to be involved in an earlier stage in respect of any future proposals.
Yeah, yes, and we welcome the national initiative. So, Councillor Murray.
I think, you know, we need to be involved all along the process because something could change, couldn't it? You know, it might suddenly morph into 4 theatres and a lovely, great big clinical centre at Maidstone that we didn't know about today. So, you know, we need to have your eyes on us, please, Rachel.
Okay, is that agreed? Agreed. Thank you very much. Yep. Thank you, Rachel. It's nice to have a good news story from you. Yes, thank you. Yes. No, but again, Maidstone. Right, members, that takes us on to agenda item 9, section 136, pathway and health-based place of safety service improvement. Taps, I believe you're going to lead on this. Yes. Thank you. So,
yes, I'll lead on that. I'll introduce the paper. So first of all, thank you for accommodating us at a very last minute. I think I did extend my thanks at our pre-meet to say it's great that you managed to accommodate us for today. So with me today, I've got Sarah Warner. Oh, who's our Sarah? Jordan.
Hello, I'm the engagement lead, so if you have any questions about the consultation plan or the engagement that we're undertaking currently, then please ask me.
Thank you. And Louise Clark.
Yes, Louise Clark, Programme Director for the ICB for the Urgent and Emergency Mental Health Pathway.
and Dr. Kasparek.
Hello. Hello, I'm Dr. Adam Kasparek, Deputy Clinical Director for the Acute Service for KMPT and Consultant Liaison Psychiatrist.
Thank you.
Welcome all of you. Sorry, over to you.
Yeah, so Councillor, I take it that the report as read, just also in the interest of time, but what the paper is setting out is seeking to usher in a new health-based place of safety and to enhance the Section 136 pathway for the Kent and Medway residents. The proposal also talks about potentially centralising the health-based place of safety at the Maidstone site, subject to consultation, of course. Currently, we've got 5 spaces in terms of provision for place of safety across the county, and the intention is very much to retain that capacity. And this has been driven really by the need to support recruitment and retention. The facilities are not fit for purpose, so they need to be repurposed. That's the driver. Plus, also, is to enhance the care that we're providing to the patients and the residents of Medway and Kent. As I said, I take the paper as read, and it'll be good for us to maybe take some questions. Thank you.
Okay. Members, Councillor Murray.
Yes, I mean, thank you, Taps, and it's good to see everybody. And I suppose the first thing I would say is that, you know, it's really unfortunate that the place of safety that was set up in Medway, in Woodlands Road, never really worked out, did it? And we had police taking people there and finding that there was nobody there. And actually, Taps, I think we mentioned this to you the last time you were here. So to the extent that some progress has been made, that's a good thing, particularly because if you look at the figures for mental frailty, Medway comes out very high, doesn't it? We've got a lot of people here, particularly interestingly enough, in the Rochester and Strood area who have got mental health problems. And given the age and affluence of the population, it's remained persistently higher than you would expect it to be. So any improvements are welcome, but I am concerned that this whole 24-hour approach to crisis has never really, to date, worked out. I mean, I think there's a very honest appraisal in the paper that speaks to the fact it's a difficult thing to achieve, that people have to work extremely unsociable hours, they're, you know, called out at funny times, that hitherto they've had to go to all sorts of different locations to make the assessments. But we've never actually really seen the 24-hour service at Medway itself. And we've had all sorts of cases of people waiting inappropriately in A&E to try and get a mental health assessment, being placed in an inappropriate medical or clinical bed because there wasn't anywhere else to put them, and a long and painful history of beds being reduced here over the last decade and beyond. So how can I have confidence that the proposals here, because the same points that I've seen made about staffing vacancies are being made again, how can I have confidence that you are actually going to deliver the things that are promised here?
Councillor, thank you for your question. I think the first thing to say is that the promise to enhance this pathway is something that I want to leave this room having assured you that we will deliver on. We have secured the capital funds to help us, potentially subject to consultation, I have to add, to really repurpose a facility that's in keeping with the prescribed national standards. So the fact that we've secured that investment gives us a degree of confidence as an ICB. we recognise that there isn't a given facility in Medway to date, and as we speak, but the options that you see laid out in the paper, they do articulate, I guess, the challenges that we face in terms of having a co-located health-based place of safety within this locality. So we believe that, subject to consultation and approval, and given that this is a national scheme where, as partners across the system, we've had to put a joint bid, we believe very strongly that we will deliver this time round. Now, I know ideally this committee would have loved for us to have erected a facility or established a facility within this locality, but it's purely down to the absence of having that co-located facility. So I do hope if these plans are approved and these proposals are approved, that we will deliver, and we stand ready to be able to account in terms of delivery of that particular facility. But you see in the paper as well, we've talked about some of the improvements and enhancements around urgent and emergency mental health, which Louise will talk about. And those are coming on stream. But I don't want to talk about that myself, but I'll let Louise try and assure this committee about some of those transformational pieces of work we're undertaking to try and support and enhance that pathway. So it's work that's underway. It's work that we are committed towards delivery. We are in the planning phase as we speak. We're making decisions about financial spend for 23-24, and all the plans that we've set out in this paper, apart from, I guess, the one that's subject to consultation, but the open access crisis 111, the safe havens that we talk about, the crisis houses, all those plans, they are being discussed actively and to be implemented as part of our planning round. But I'll let Louise add a thing or two on that, Councillor.
Thank you. So the proposal here is specifically related to the health-based place of safety, which is a statutory requirement to provide a place for police to convey individuals detained under Section 136(2). And there isn't one currently within Medway. There is an urgent and emergency care pathway transformation programme that was launched last year. The underpinning philosophy of the urgent and emergency care pathway is to prevent individuals in crisis having to spend time in emergency departments. We want to offer a true alternative for individuals in mental health crisis, and in doing so, not only will it provide a seamless pathway for service users, and of course prevent service users from needing to access the emergency department, we also, as part of our programme, will be working in a much more integrated way with ambulance services, 999 and 111, and the third sector to deliver a range of community crisis alternatives. Specifically for Medway, as you've described, there is a safe haven currently. We know that safe haven is underutilised. We've held wide stakeholder workshops looking at what can we do to increase usage and footfall and confidence in the safe havens, working with CCAM, Kent Police, experts by experience, and we have developed a model that is a hybrid model of clinical and third sector provision. Our learning has been from particularly our CCAM colleagues and our police colleagues is that currently they don't have confidence in conveying individuals in psychiatric distress to a purely third sector run service, and that preferably they would rather convey to an area that's co-located with a district general hospital site. I've lost my train of thought, sorry. So, yeah, so we are working in partnership with KMPT and to further develop that hybrid model. We've also put mental health nurses at the front door to the emergency departments. We already have liaison psychiatry services based in each emergency department across the county, but we're actually putting, we've put mental health nurses at the front door to the emergency department to try and stream individuals away from the emergency department to the right the right service, and the idea would be that if we had a co-located hybrid safe haven on a hospital site, our triage nurses could divert and stream individuals to there. We also are, our intention is to place a crisis house in the Medway area. I don't know if you're familiar with the concept of crisis houses, but they are solely third sector delivered, but they have they are an alternative for individuals who are in mental health crisis but who probably don't warrant acute inpatient admission. So there are a range of community crisis alternatives that are planned for 23-24. This particular scheme is part of that, and there has been an improvement plan in place for the Section 136 revised pathway since 2017 that has reaped dividends. There's been a significant reduction in 136, particularly over the last 18 months, by roughly 45%, and that's because we've implemented a police mental health advice line whereby officers have the opportunity to speak with senior mental health clinicians to talk through it 24/7, to talk through alternatives to using their powers of detention. I don't know if I've answered your question.
No, I mean, thanks. Sorry, if I can come back, Chair. I mean, you have partially, but, you know, I think it must be 12 years since I first heard about a crisis house. And it was going to be set up in Medway. It was presented very clearly, and I appreciate not, you know, perhaps in your time in working with this, as part of the rationale for taking away inpatient mental health beds. And in fact, we saw quite a developed study on the effectiveness of crisis houses, and then it never happened. When we've just had our GP services task group, we heard from GPs there who said they are dealing with an enormous amount of mental health problems that they feel unprepared and untrained for to cope with. They said that quite openly. We've heard from the ambulance service tonight talking about the fact that they're finding that they've got more and more mental health calls that they feel unprepared and untrained to cope with. And the police have been saying it for a long time. Now, you know, I can accept it in the case of the police that they probably resist saying that they feel prepared because they just don't see it as part of their job, even though they do attend and they do the best they can. And like I say, they've had a pretty ropey experience with the place of safety. I mean, I've heard, never mind it being only third sector run, you know, I've heard of PCSOs being told to take somebody there and there being nobody there at all, and the doors are locked and the lights are out and they're still... So it's not very surprising that people resile into a Section 136 because, you know, they probably know it's inappropriate, but they end up thinking it's the only thing that they can do to keep a patient safe. You know, this does seem a more joined up thing, but you'll forgive me for feeling cynical, because this has been such a problem for such a long time. And actually, it's fair to assume that the problems with mental health crises have got worse because this has been such a problem for a long time. That you know, people have, everybody right across the system, including the person in a crisis, expectation is that they'll end up being sectioned because that will be the only way, really, that anything actually is going to happen that has got a kind of lasting impact on the way that they're feeling. So, you know, look, this seems very well intentioned. You're saying that it definitely is resourced. You're saying that the ICP are behind it. I'm sure clinicians like Dr. Kasparek will, you know, throw his weight behind it and want it to happen. But until I see it, I think, you know, and like to see it, I would like to physically see it and think about how it's going to work and hear what patient, and, you know, doing another consultation, I'm afraid, doesn't fill me with joy either, because it's actually quite painful going to consultations that involve mental health patients. And every time I've been to one, they say the same thing. I have to tell my story over and over again every time I have a crisis to a new set of people. And my family don't think that they've got any support. And when they try to make a referral about me, they're told, no, the person who's actually suffering the crisis has to make a referral about them, and so on and so forth. You're all nodding because you've all heard it all as well. So, you know, I suppose what's going to be different about this that isn't going to lead to sort of nothing much happening as it has in the past? You know, I'd love to see a crisis house here. I would love to, more than one. I'd love to see the 24-hour service at the hospital door really being there and not being dogged by recruitment and people not being able to turn up or being called away to do something else. I would love to hear mental health patients say that they've got full confidence that they'll be looked after, and that the police being genuine, saying, yeah, we have reduced 136 because we don't feel like it's our only alternative anymore.
Thank you, Councillor. I think we were nodding because we agree with you that promises potentially would have been made in the past and delivery was scarce. And it's not a record that we're proud of. I think nationally there's been a change in terms of what is loosely described as parity of esteem. What that does, it introduces a mental health investment standard, which is ring-fenced and protected. So with that, it gives us an opportunity as an ICB and as a system to truly invest in mental health services. Because in the past, I wasn't around, and I wouldn't want to hazard a guess why some of those initiatives didn't materialize, namely the crisis house. But what I am saying, I guess, and the change that is come into play is the budget is ring-fenced. It's we have to increase our spend on mental health priorities. We also have the long-term plan, which articulates very clearly the mental health priorities, and everything we're setting out today is driven from and stems from the long-term plan. So this is us as a system responding to the needs of our population, but equally seeking to improve and enhance those pathways for our patients. So we sit assured, knowing that financial resources won't be an issue for mental health because of the protections that come, which is a national sort of directive and initiative. You talked about some of the challenges that colleagues are facing, whether that's CCAM colleagues or GP colleagues. I know when I was here last time, we were talking about some of the improvements that are underway across mental health and the 4 programs we've got, but I won't labor on those today. So we've got the Community Mental Health Framework, which we will be piloting here in Medway as a trailblazer site, which will seek to transform all our community mental health services. I think we talked about this last time, and I will come back to this committee with an update post the pilot. So we've got all those programs which are being introduced thanks to this mental health investment standard. So I could catalogue equally the different investments that are coming. But I think for me, in this capacity, I stand reassured that actually the conversations we're having with colleagues and across the system, because we've got this pot of money, We just have to now execute. And that is really why I would hope that this will be music, as it were, to your ears, and hopefully you will be able to also hold us to account, asking us that tough question around when is this going to materialize, when is this going to happen. So that gives me the confidence. I don't know whether colleagues wanted to add a thing or two about that.
I think I wanted to say the community framework, of course, is designed to prevent people from going into crisis in the very first place, and the urgent and emergency programme dovetails well with the community framework. So the emphasis is on prevention of crisis in the very first place. As TAPS has described, there is dedicated ring-fenced funding for the services that I have described this evening. So the crisis houses, there will be more than one crisis house. The plan is to commission two, one for Medway and one for the east of the county. And in March we go live with our NHS 111 Select 2 for mental health. I don't know how familiar you are with that, but individuals in crisis can call NHS 111, and rather than go through the lengthy algorithm that they would have to currently, yeah, you're aware of that. I was around in Medway. I was formerly the matron of the mental health inpatient unit at Medway, and was very sad when the wards were or the beds were moved. My reflections back now compared to them was that there wasn't the integrated working between system partners. I think we were probably working in silo. CCAM, ambulance services, police, blah, blah, blah. I think what has really developed, particularly over the last 12 months, is a very strong system leadership approach with our system partners. We've got a system governance structure, and I think relationships have strengthened, and I think that the interdependencies between partners are well understood, better understood, and the pathway that will be developed now will be a truly integrated pathway rather than piecemeal funding in different areas.
Okay, thank you. Councillor MacDonald.
Thank you. And I want to start off, I'm not going to go on too long, but I want to start off by saying, of course, it's a good idea, because your mental health is a real issue. It's a real issue. I will say, though, Louise, that I heard about this wonderful partnerships when the CCG was around. Do you remember? The integrated stuff, and how wonderful, and how everyone's together, and how everyone's aligned. And we said then that it wasn't going to work, and here we go again now. And I hope the ICB and all them are working together, but I think the proof's going to be in the pudding in years to come. I just want to reiterate again that Woodlands site, you lost trust there. The trust was lost. People were sent up there, charities sent people up there, the police took people up there, family members took people up, and there was no one there. It was appalling. That was a funded service. That wasn't just a little voluntary thing. That was a funded service that let this community down. And more importantly, let someone in crisis that would end up maybe in worse crisis because they were left. And you would have seen them on the ward probably later on. If they would have been caught earlier, then things would have been done. So you can see why we're a little bit, we're not against the actual idea, but believing it's going to happen and work is another idea. And there's members around this panel, around this table. Remember when we were fighting the loss of the personality disorder service that we lost here, that CAMPT closed down, that we lost, which was helping many people, and we lost that. And we lost the mental health wards. And I'm not going to go back in history, and not at this time of night, but I'm just saying that's why we're a little bit dubious about the process. So I think for me, there isn't the individuals at the emergency departments you talk about. Many times police are called because they're individual. You have someone turn up there, someone be in crisis, but there'd be no one around to deal with that. I'm not saying that the doctors and the teams are not there, but they're busy anyway. But sometimes it goes into a crisis point, and the hospital can't deal with that. So there probably is during the day, but maybe if you go in there at 2 o'clock in the morning, you won't be getting someone. And I know that from from experience of bringing people to our local hospital. So, you know, again, when we make promises, and I'm not saying you are TAPS, definitely, but when you make promises that someone's going to be at that door, our residents will expect someone to be at that door, and not what Councillor Murray was saying, like Councillor Murray was saying about all of a sudden lost, or they're on leave, or they're off sick, or you want to follow through on that promise to make a real impact in mental health, because we're not making that impact. Doctors and once you get them in and once you work on them, of course you are, but we're not making that initial impact, which will save you a hell of a lot of work going through the system. I just want to talk about the Sarah again, with the consultation. Yet again, I always see VCS. I never see a breakdown of the VCS you're dealing with. Now, from personal experience, and I will say for Councillor Price as well, we deal with charities, advice charities, for example, that are your third emergency service. They sit for hours with clients. Volunteers sit with hours with residents that are going through mental despair. And we have to wait for police to arrive, or we have to wait for something to happen. Sometimes 3, 4, 5 hours taken up. And your voluntary sector organisations, not just the VCS network or Health Watch, your voluntary sector organisations, I'm going to say like your Men in Sheds and your advice centres across the whole of Kent, not just Medway, are dealing with this issue on a daily basis. And it's not having a go at you, but when I turn and look at the consultation plan, which I always do, and this committee knows, I always harp on about the charity sector, probably because with my other hat I'm in it, I never see that consultation with key partners that are dealing with your crisis every single day, where residents are bringing someone in and saying they can't cope with their tenancy, they can't cope with their house, they're going to be evicted, they're going through a mental breakdown, what should we do? We're not getting the support. They're the people that also need to be spoken to. And in 13 years of service in Medway, with my other hat, I've never, ever been approached. Ever been approached. I'm the chief exec there. I've never been approached by KMPT or by mental health, or even by the NHS, actually, to say, give us some feedback. Never. And I think it's really sad. I'm not having a go at you for it, but I'm just trying to leave you with something that you maybe want to take away with you, because it's a real big thing for me.
Absolutely. I appreciate the suggestion. We have and are working with the charities that we know are trusted confidants of people with severe, complex mental health, emotional disorders at the moment. So we're working with Speak Up, Megan CIC, Rethink, Mind, Mental Health together. But we recognise and have a list of organisations that we want to cascade the information that we're undertaking this to help encourage people to come forward, because when we're talking about this extremely vulnerable people at the worst state, when they're pushed to that point that you're talking about, where they really don't feel like they cope and therefore they end up in an emergency state, it's very difficult for them to find that trusted person to talk to. And if they found you and any organisation and they feel able to articulate it, that's what we want to hear from, and we don't want them to be forced to repeat it just so that I can write it down. We just want to be able to say, if they've told you about it and you've captured something about it, please send it through to us. So we will absolutely take that as a suggestion and broaden our scope of who we are.
Okay, just finally, Chair, I think I just, you know, and maybe I'll send you an email, but I think, you know, remember, those charities I'm talking about, and it could even be Street Angels, could be anybody. Those charities are dealing with individuals that have no food or in trauma, they might be just released from prison, have mental health difficulties. These are the charities that are the front line, and can help you and do that, not diagnosis, but do that bit of work for you. But then if they're sending them to your crisis house, which hopefully does come to Medway, but if they and then there's no one there, the charity is losing the trust of that individual, plus the individual, which is most important, the individual is getting a poor deal. And I haven't yet seen, and we've had KMPT on this, come and talk to us, I haven't yet seen something that leaves me reassured when I leave. And that isn't about the doctors and everyone else about the work. I've not seen any progress, really. We've been talking about the eating disorders for a long time. I've not seen any progress which leaves me leaving the room thinking, wonderful, this is going to be great. Because unfortunately, I'm at the stage now where I look at the gaps Where's it going to go wrong? And maybe that's where we don't have to go down that road here around this table, because we're looking at what you're presenting to us. But sometimes using those partners, that can be a real asset to you. You're really missing out on a bit of a nugget there, because they are the ones that can actually help you and talk to those families, talk to those residents who often see them on a weekly, daily basis. Hard to reach ones, hidden communities that maybe you only see when they're at trauma, at crisis point. It's just a note I want to say. Thank you, Chair. Thank you.
Absolutely, take that suggestion and we'll work with it. Thank you.
I just want, thank you, Councillor MacDonald, on that one. Beyond the consultation, I think you touched on a number of items there in terms of just general engagement with the voluntary sector. We do have voluntary sector providers actively providing safe havens to date here in Medway. But I was just thinking that one of our strategic intent as the ICB is to really work closely with the voluntary care sector. If Paul was here, or Vincent, they'll be saying the same. But, I think what I'm just thinking aloud here, for mental health, the way we're organized, where every other part of healthcare system is going to the health and care partnerships, mental health, we've got a provider collaborative. So within that provider collaborative, the membership of that provider collaborative has got third sector representation. So I wonder, given you're hearing some palpable shop floor conversations, as it were, I wonder whether it might be worthy us exchanging notes as well when we reach out. Sarah, yeah, please, thank you.
Okay, thank you. Councillor Purdy.
Yes, I think you can feel that we're not terribly inspired. And despite my complaints all the time about the one at Woodlands, nobody ever listened. It certainly wasn't a safe place. If you went there at night, it was pitch black, and you couldn't see you didn't know whether somebody was in that building or not. It was scary. And I did bring this up several times, saying that it should be lit properly, but nothing got happened. And anyway, that's all history. But we're not talking about just people. We are talking about people who are in crisis. They're not going to be somebody you can take their hand and say, come on, darling, we'll take you here or do this. They're kicking off big time, some of them. I had a lady phone me. Her daughter was smashing the house up. She didn't know what to do or where to go. Eventually, we went down to KMPT down that. And when the daughter got in there, she'd calmed down. And it was all roses and light, and they prescribed her something. We went out in the car park, and her actual words were, I'm not effing well taking those tablets. Threw them down on the floor and run off. And the mother was distraught. She didn't know where her daughter was going. What we actually want is proper care. She was really, she shouldn't have never been sent out into the community again. There should have been a safe haven. Fortunately, she has finally gone into a safe haven, but it took a lot of time and distress for the parents. And that isn't the only one. I could go through a whole list of people that I've tried to help, and we've not got anywhere. It's frustrating. It's more frustrating for the parent or the carer or the wife or whatever it is, because we just don't know what it must be like to have to live with that. So we do need safe havens. We do need these people having proper care. And like you're saying you're going out to consult. What are you going to go and consult on? You know what's needed. We sound like a lonely lot, but I only think because we want the right service.
I agree with what you're saying. What we're going out to consult specifically on is the three current health-based places of safety across the county for 136. So that's we've had this opportunity of capital funding which we think will be a real enabler of improving the pathway of care for people detained specifically under 136. I myself went to the safe haven when I first came into post in Medway and share your concerns, which is why we have, as I've aforementioned, held 3 multi-stakeholder workshops to look at what would work, what would encourage the police or encourage CCAM to convey? What would it look like? What would a safe haven need to look like for it to be utilised? And we've come up with a model that I previously described, and we are absolutely committed to delivering that. And what we don't want people going to ED and speaking to the mental health nurse at the front door. We don't want them even getting near to the emergency department. So we do hear what you're saying, and I've been working in mental health in Medway for some time, and I understand your reticence, and I hope that we can come back here, in the not too distant future to showcase what we are going to provide.
I would just like somewhere where if somebody's phoning me and they're distressed, I can feel confident that I can either take them or direct them there and know that they're going to get the proper care.
I just figured I'd just jump in real quick just to kind of say one thing. Most people who work in mental health choose it not because it's like the only job they could find. It's actually usually a calling for most of them. So I understand. I'm hearing a lot of personal stories, and they are heartbreaking. And I see those heartbreaking stories every day, and I actually try to deal with them every day. I hear your comment about liaison. I actually work in liaison psychiatry. It's not the easiest job, but I actually prefer that job. I actually chose to have that job and chose to go into that calling. And I actually, all of these suggestions are things that we try to do on an individual basis. But that's not the point of today's conversation. We can go into that. I'm happy to talk to you after this meeting and go into great detail about that if you want. I personally believe an ounce of prevention is worth a pound of cure. I also believe in trying to figure out where things fall out in the boundaries and stuff like that, which is beyond the scope of today's conversation. But like KMPT doesn't own the eating disorder service, so we don't have a tender, so we can't fix that problem. But going back to what Louise Clack was saying earlier, also outside the scope of today's talk, but more than happy to talk about this, make sure that you guys know moving forward, there is more investment, and it's a great thing for me to hear that there is this investment, and it sounds like we're both saying the same thing. I'd like to see more. I like to see more too, and that's why I've been involved as a deputy clinical director to help develop, for example, the new crisis teams, which used to be just holding someone. Now we're trying to implement biopsychosocial model. For the first time ever, we're going to try to recruit social workers, occupational therapists. We had a few of pharmacists to get the medication right, and actually psychologists to make sure that we have this wraparound service. So we're not just trying to solve things in 24 hours. That's just a legal framework, 136, that we're talking about today. But certainly outside of that, we're doing all of these other things, and I actually have to commend these people here. That's something that they're doing, and we want to have working as well. But going back to the point of today's conversation, because I think that actually all I'm hearing is that we're more or less on the same page. If we can make a better service, we would like to talk about that and see what we can do. And the concerns that I've been hearing about people not being present, that's the advantage if we try to make a service that is more patient first, kind of making a safer environment, trying to decrease the time of detention for these people who are restrained against their will, and focusing on well-being and making a more conducive, friendly environment that is not dark, not disheartening to visit. And that actually is our aim. And with money, I don't see how it could get worse. It can only get better, I would hope. Thank you.
Thank you. If I can ask just a couple of questions. Could we have a briefing note on the finance that is coming through on new money? Sorry, without my glasses, I can't see the lady's name next. You said, and shortly we would like to come back to you. Your chart on page 161 of the consultation process, when do you expect the consultation to finish? And can you come back to the committee after that?
So we're intending to run the consultation for 2 months. between the 20th of February and Easter, 7th of April. So we can come back to you after that. We'll take a couple of weeks for the independent analyst to write up the report and make sure that what was heard is clearly articulated.
Because there's an election in May, that will probably postpone it. But if it's allowed, if you could send us that report to all members. Well, yes, yeah, the June committee. But if we could see it April when it's ready, you know, if you could send it round then, because some of these members, us members, might or might not be here, etc. So, and we're all interested, so we would like to see the report. And then if you could come back to the June meeting.
But we get an update on the consultation on a briefing.
Yeah, yeah.
I thought the briefing note you wanted was on the actual ring-fence investment for mental health.
Yes, that's separate to...
Okay. Okay, fine. Yep, sure. Thank you.
Okay.
Okay. Thanks.
Okay, thank you. Councillor Purdy.
We know the proposed get it right.
And members
I'm
again,
moaning at you and I can't even get it right myself.
I assume we don't
can I?
want an SV.
Yeah. We note the proposal to improve the mental health urgent and emergency care pathways and support the plan for a 2-month public consultation period. Is that agreed?
And the proposal does not constitute a substantial
Variation, no.
Yes, the members agree with that? Yes. Okay.
Yeah.
Thank you. And thank you all. Thank you.
I think they say 12 years, it's longer than 12 years.
Right, members, that takes us to agenda item 10, the GP Access Task Group, the interim or not report. James Williams will introduce the report.
Thanks, members. I've got Dr. Logan Manicum as well in the room. Unfortunately, we've lost our ICB representative just because they have had to leave due to urgent matters just a few minutes ago. Members, GP Access, you've got the report. I think one of the challenges that we all face, and I've listened tonight and even the last topic, is the system is a very vicious place at the moment in relation to the challenges that are based upon it. And by the system, I mean in the NHS and social care. And the relevance to all of the reports that we've received tonight is that primary care is the front end of that system, which is why this topic was chosen as a very important piece for us to look through. And equally, we knew at the time, and clearly it was made clear to the committee, that it would be a difficult time for primary care colleagues to engage because, clearly, as we're aware, the system timing, the NHS is in a very difficult position at this moment in time. That all said, the report has set out is quite comprehensive in my opinion. It's gone into quite a lot of the areas, the recommendations, of which there are 14, will deliver, if accepted, change, in my opinion. I referred members to item 6.19 in the report, if you haven't looked at any of the areas, because one of the things that we've been trying to do, and I believe has been uncovered through this process, is looking not just at what GPs do, but at what tools we have and can be made more available within our community to support the work within primary care. And that's the items around social prescribing. So there's quite a lot of good evidence heard and taken from that position. The other point I'd just like to refer you to before I hand over to Logan is 6.24. And that refers specifically to the incentive scheme to increase GP capacity within Medway and other areas, but we're clearly interested in this committee within Medway. And what you've got there is the fact that Medway Council, not least because we are a housing authority, but we've been very proactive in working with our NHS colleagues to facilitate the recruitment and retention of additional GPs. And there is now an advert that's out, there's a link, it's out in the Pulse magazine and all around the place, trying to get people now to come to Medway. There was meant to be a webinar a couple of weeks ago. It was cancelled because of some of the challenges within the NHS, because some of the doctors that were going to speak to that to encourage other people to go were stuck in practice, but they're going to reschedule that later on this week. So in terms of the actual overview, I know that the recommendations are set out, and I'm going to pass to Logan. The discussion for this particular committee is, do we want to send forward this interim recommendation or come back to it? But Logan, I'll pass to you just to go into any more detail you might.
Thank you very much, James, and thank you everyone for the invite to present this task force report to the committee. So I think when I first was approached by James in the summer of last year to sort of facilitate this task force, you know, we looked at it even in the setting the scene context, of just looking in the context of just primary care and access to primary care and what does it mean for the residents of Medway. But if I ask colleagues to perhaps look at 3.2, which is sort of the main sort of key lines of inquiry, actually over the course of 6 months, we actually went far beyond the key lines of inquiry. There were many things on digital literacy, social prescribing, communications, many things that we didn't actually consider which would be particularly useful to support primary care colleagues in actually helping them improve the care of residents in Medway. And so beyond that, whilst initially I thought, and I was worried, that it might have been quite adversarial between GP bashing or ICB bashing, it turned out to be very collaborative in nature. What unfortunately my colleague Cheryl Turner and ICB couldn't attend, but Suk Singh, who's essentially her boss, was there throughout the entire process and been very helpful, and surprisingly it turned out to be a very collaborative process and very informative for me as well, being a secondary care doctor in Medway Hospital. So as James said, these are interim recommendations, and this is largely because the picture both in Medway and nationally is shifting constantly, but there were many good recommendations here that we can start the process of implementing and then come back at a future date to say this is what we have done thus far, and here are potentially our next steps to progress. And with that, I open to questions and queries.
Councillor Murray.
Well, the first thing for me to say is a big thank you to yourself, Logan, to Suk Singh particularly, who, given his position in the ICB, showed tremendous commitment and, you know, gave us a lot of support, to Terry Reynolds, to Michael and to Umi, all of whom helped to facilitate the report and put it together. And from the Labour Group's point of view, we want the recommendations to go to Cabinet, we want to see them implemented, and whether it comes back at another time, it makes sense to report on how the recommendations are going. And as you have said, James, the recommendations are capable of achieving change, and the Council's got a big role to play in them. And I think, you know, Logan, you're not the only practitioner who was, you know, everybody surprised each other. There was a very collaborative atmosphere. People were very honest, and practically everyone we spoke to said they were glad to come along and speak to us. And that includes people from right across the spectrum, including pharmacies and so on, and were pleased to be listened to. And lots of people asked, what are we going to do with this? So if we leave it on the shelf, because we couldn't speak to as many GPs as I'm sure we would all have liked to do, I think that would be doing a huge disservice to the expertise and time and really good things that we learned about it. And Suk, you know, was happy to map it to the ICB strategy because he said the level of engagement taught him things about how engagement should take place when you're trying to work through service improvement. And I do wonder, when would be a good time? When would be the halcyon day when there's loads of GPs available to come and see us and talk to us? The people that we saw made a commitment, and for the Labour group, for Adam and I, we saw enough that matches the national narrative to tell us that we were getting a really good local picture of what was going on. And one of the really encouraging and optimistic things was how everybody we saw had a contribution to make and thought about innovations and things that could happen to improve it. So I think we would be doing a huge disservice to everybody that took part if we don't send it to Cabinet and try to make a start on some of these recommendations.
Councillor Lammas, did you want to come in?
I think it's ironic that the report couldn't access GPs because it's so busy. And this is something I really wanted to get involved with, and I was told I can't participate in this process because I'm work full time. They couldn't possibly meet the meeting schedules and engagements with GPs around my work commitments. So it's just absolutely hilarious to me that the fact that I was so keen to get involved in the sort of process of this report, but I was told I can't do it because my work commitments wouldn't match that works for the committee. And then here we are with this. Chair, I do hesitate to criticise the report because there are some good things about it. But, and you know, the fact remains is that there are more than 10 pages in this report per Medway GP you spoke to. You went to 2 practices. Like, it's less than 5% of the registered GP practices. And when you look at the number of GPs that work in those practices, even less of a percent than that. Because I wasn't involved in the process, my first question, I guess, would be, how was the approach done to GP surgeries? Because in the time that this report has been being conducted, I've had reason to visit my GP. My mother has had reason to visit her GP. Both times we went there, we go, oh, by the way, do you know that Medway's doing a task force review on GP access? And they're like, really? Oh, I'd love to participate in that. And then the GP, despite only being able to discuss one issue in the set time period, volunteered information to me anecdotally. That's the level of engagement. Did people not just go in and knock on the door with like clipboards and just say, can you spare 5 minutes? Like the level of engagement I got anecdotally was huge. I really struggled to understand why only 2 practices were, you know, gave evidence and, you know, such a little number of GPs. I think that the problem I have is that there is a national problem with GPs, but the South East has an even worse problem. But Medway has a really, really big problem, even within the South East. So when Councillor Murray said, I've seen enough evidence to match the national narrative, that worries me because I'm not looking for enough evidence to match the national narrative. I want to know acutely why there is a problem in Medway and why there's a problem with my constituents in Princes Park versus the South East versus nationally. Because there is a big problem in Medway of access to GP services. I would say this is my #1 problem on the doorstep for the constituents. So I just really don't think that this can carry weight at this stage with so few GPs visited, and I would like information on the methodology for contacting GP, and I'd like work to be undertaken this year in earnest. Why not start now and knock on those practices' doors and speak to those GPs?
I can assure you there was a lot of work put in to talk to the GPs. So, Councillor MacDonald.
Chair, can I just say, I mean, I know Councillor Lammas and I, we've agreed on other topics tonight, but I've got to answer back, I think, because, #1, can I just thank the task group for doing it? I mean, we're not an all-parliamentary group. It's not a year's task. It's a very short. I mean, I've got a real interest in it, but I was busy, and you can only have 2 members from each. It's got to be a fair process. So, you know, there's certain areas over the time I've been on this committee I've been interested in social isolation, dementia, and we all jump into where we can go. But we only expect our group to be able to get a flavour of what's going on. They can't visit every GP in Medway, unless it's going to go over a 2-year programme, because I'm sure James and the people on it, you're not always going to be able to access those GPs. I understand what you're saying about getting a wider view, but I would almost say, and if you're getting on the doorsteps, I certainly get it with all the different outside wear, I think that the feedback they got via the GPs in those 2 surgeries will be very similar, unless you're going to go to a rural different one out in the middle of nowhere, will be very similar to the others, because they struggle with different things. It's not a challenging thing, Councillor Amos, honestly, I'm not. I'm just trying to make a point about this brief piece of work, because it was a brief piece of work that doesn't take up all of our time, because we have many other issues.
The last time the task group sat round the table and went round and round this, it took 2 hours and we still didn't reach agreement.
Yeah, Chair, can I just finish? I'm not going to read. I'm not giving you I'm not going through another long documentary. I was just finishing on my final point. That's all I was doing. I was just saying, from what I've read of the report and from what I've read of the recommendations, and even from Logan and James, it'd be a real shame to not put that through to Cabinet. That's what I'm saying. It'd be a real shame, because it's a waste of our work. It's the waste of all of your councillors and officer time if we're just going to say, let's put that aside and let's go and talk to another 50 GPs. It's never going to happen, Chair.
Can I pick up on some of your points? You said some GPs. We spoke to 3 Medway GPs. That's not enough, in my view. That's not enough. We did not speak to a rural GP. We did not speak to a locum. The facts and figures on page 177 about GPs access in Medway. Every other time this committee, HASC, has asked for GP numbers, they've been given without locums. Now we're being given a report that because locums have suddenly increased dramatically, we don't know whether that's going to continue. We don't know whether those locums are going to stay working in Medway. We don't know what drew them to Medway. There are so many questions about GPs. And if you look on every page of the report, it starts GP access in Medway. Now,
did you ask though, Chair? Did you say, can I speak to a local? Did you say, can I speak to one rural GP?
Our officers, especially rural GPs, yes, for weeks, because where this come from, Business ONS, they were very adamant that we should speak to rural GPs. They were so adamant that this work should be completed that they said it should and could take as longer than the normal. So to me, that means not that it can go on indefinitely, but another 3 months because of the election again is not going to cause any problems. My worst nightmare is, yes, we pass interim reports with one recommendation in particular that's ridiculous, that we write to government because this is what we think after having spoken to 3 GPs, or we ask Cabinet to write to government, is ludicrous in my opinion.
We've done that with other task groups, though, Chair. We've done it with dementia one, we've done it with social isolation.
Not when we've spoken to 2% of whatever the criteria was. Right, so I suggest we go to the vote.
Well, Adam wants to speak. He was on the task group, and so does Logan.
I would like to speak again, Chair, because the amount of time
Right.
Elizabeth, actually.
But we will just go round and round. Go on then. Sorry, if it was so important, perhaps you should have turned up at more than half the... yes, right, carry on.
I'm going to report you to Council of Conduct.
Right, fine.
Okay. Right, first of all, there was not that consensus right at the start that we would actually have this task group at all. But that's really what's behind this, I think. There has been lots of work that's been put into it. I found it fascinating. I also found that the thing about access, we called it access to GPs, it was actually access to primary care. And we
Thank you. I just want the work completed.
Yes,
But it isn't. We haven't seen it. But does it matter who sits in what chair? Members are interested in GP access. Sorry, Logan, you wanted to come.
Every single item we've spoken about tonight, we focused on unable with GP. With Jane, we've spoken, you know, Chair, every single item we've all brought in about the GP access and what problem it is. We've all brought in.
So it is important that we get the GP's point of view. Right, sorry, Logan.
So, Councillor, I think just to come back to Councillor Lama's point about methodology. So, you know, because we recognized that from the beginning in June, there might be difficulty in getting GPs or just primary care staff members. So we took a very comprehensive strategy to use quite a few routes to contact GPs. First, directly via GPs, via ICB comms, so the communications team, via Suxing directly, and also via the LMC. We actually had originally planned visits over August, September, and also in December, in the December session. But they were all stymied for a variety of reasons. One was the COVID surge in August, the Queen's mourning period, so we had a few that was cancelled. And in December, in the 15th December session, we actually had 2 GPs planned, but Group A strepped, obviously forced them to cancel those sessions. I think on average, I can come back to specific numbers of approach GPs, but I think looking at all the tons of emails, I think it's at least 20 to 30 GP practices we actually approached, and it booked probably about 10 in total. But a variety of cancellations just force our hand. I'm just making the point about methodology and approach numbers, and I'm quite happy to come back and actually give you more numbers. So I think there's a caveat. But having said that, we also were able to get other allied health professionals into the mix, which was quite interesting. I think there's a risk, and I will point out, which is why the risk is identified, is it's possible that you may not identify or be able to get more GPs considering this constant pressure, and you're somewhat stuck with the other risk that there's shifting national and local pictures, that the recommendations that currently as it stands may become irrelevant, and you can't action any of those bits. And I'll just point out some of those bits. That's it, my head.
Thanks, Chair. And Logan picked up, hopefully, just give some context around the issues around getting GPs into that space. The other thing just to reflect on is that we were able to get a GP colleague from another area who'd been through a similar process to act and give us some insight as to what worked and what didn't in that particular patch. And just for reassurance, members, I'm hearing the debate, and it's a really powerful one, because at the root of all of this, I think all members in this room are trying to advocate for the Medway population. I think that's why this issue is so important for all of us. One thing as well sat there, Chair, just thinking through, we may be able to, and leave that with me, if you might, and if this is acceptable to members, GPs have protected time events where they're all brought together and they do training around specific issues. That might be a better way to utilise their time, because they're going to be there, and that will give you coverage across all of the people who are actually in there, and including not just the GPs but other colleagues. That might be one way, and particularly Councillor Lamas, your points around making sure that we're actually engaged with more than just a small proportion, but it might be something that we can plan into that. We can have some dialogue with the Medway PCNs and the healthcare partnership to see whether that's something that can facilitate. That all said, it's a member decision in terms of the current debate, but I just want to just give you that reassurance, members, that it's not for lack of trying, and clearly it's just the circumstances as to the previous year has meant that clinical prioritisation has been the rationale. The GPs have been treating our residents, and that's why they haven't been able to attend in that kind of practice. But just that point, Chair, in terms of the ability potentially to bring members into one of those protected time events, and we could probably do, well, I'll not say we probably couldn't, we can do a session with them. And then the other thing, it's just come to me, because we're doing the refresh of our joint local health and wellbeing strategy, we will be going out and consulting with our stakeholders, which include primary care and GP. So we'll be doing that as well. So it may be that we can pull in a bit of that process to link into some of the issues. But that all said, Chair, I'll leave my advice as it was, but it's clearly a member decision as to the decision that you need to take tonight.
No. That's...
I'm sorry, Chair, but the Labour group have had about 5 times more time in this debate to speak than this side has, and you haven't even heard from Elizabeth.
Who's only just put her hand up? Go on.
Thank you, Chair. I mean, I think we can all agree that, it's probably not ideal that the number of GPs that we did manage to speak to. I think we can all agree we would have liked to have spoken to more. And we would have liked to have perhaps spoken to more of a rural, setting as well. I represent a rural area, so I certainly agree with that. However, I think Councillor Price made an important point that although it's a GP access task group, we soon came to realise that it wasn't just about accessing GPs. It was much broader than that. It's about accessing other medical professionals, which then opens up the ability to access GPs, and frees up their time. So, I would agree. I'd agree that to just put this on the shelf now would be a waste of everyone's time in what we've done. I mean, months in the work. I know how hard Terry Reynolds worked on this, trying to get those appointments. It wasn't through lack of trying, and I think it sort of speaks volumes that, it wasn't the case of GPs not wanting to engage. It is that they are incredibly busy, and that's part of the problem that we've got with the access. And some of those appointments were cancelled for, there was at least 2 I remember that were cancelled due to COVID, people catching COVID and not being able to attend. So I think I worry that by sort of not sending this on further and continuing with the work, how would things change if we were to continue with it now or to leave it for 6 months and come back to it? Would we have a different experience to what we've had? I don't think so.
Well, my view is if you do an interim report with, as I say, particularly one of the recommendations is ridiculous. On the other recommendations, we should at least have GPs' views. So it goes forward now and it will be the end. It will not come back. Call it an interim report, that will be considered over. If we suspend it, delay it, but we give it a timeline to come back, then that is in the council diary. That should come back and it should happen and it should finish. So all I'm advocating is that we complete what we started to do. You and a couple of others have said we lost a couple of meetings, which is a couple of months, to COVID. So that means instead of being the longest task group, this will turn into a shortish task group when from the start it was agreed it will be a longer because it would need to take more time than most. I could go into, if you look at page 164.3, scope of the review, what we all agreed to establish the roles and responsibility from NHS through to GP practices in relation to access to primary care. I'm sorry, seeing 2 GP practices that work in totally different ways is not looking at GP practices properly. Again, 3.22, identify national and local pressures that impact on GPs and the primary care access. You need GPs' views on all of those items.
Could I just say one thing, David, before you go any further? These are doctors we're talking about. We mean nothing to them at all. They're not interested in impressing us. They will go ahead and do what they want to do because they are doctors. And I know, because as I say, I worked in a pharmacy for many years and I know how doctors react. Robert makes it sound...
The GPs we saw were very happy
Robert
to speak
makes it
with
sound
us.
very easy that you just knock on their doors and they'll talk to you. Please believe me.
Can I describe what the problem that I have, Chen, I will be brief,
Right,
is that...
and then I'm going to the recommendations.
Is that basically, what I want to know is why Medway has an acute problem with GP access in Kent, in the South East and in England, on all measures. Every recommendation in this report is like a baby version of every recommendation of every report I've seen GP from every APPG group that I've ever attended or seen. And they have a much wider involvement level. Digital literacy, resharing messages from other groups. None of these are unique to Medway. There might be an issue with attracting Medways that don't want to live near Medway versus other opportunities they have. Therefore, there might be a case to be argued on the basis of a sound evidence base to require more money to be paid for our GPs, or some sort of bespoke local service offering that we can give them that makes Medway more attractive versus the rest of Kent or the rest of the South East. That's what we need in the evidence base. That is what will make a difference, not a playbook of an attempt. And it's ironic to talk about APPGs. The Secretariat of APPGs is provided always by the private sector, which is really ironic. So I don't think this report achieves anything it set out to do. It doesn't answer any of those questions.
Right. I'm now going to the recommendations. The one I would like to make is I would like to propose that the committee notes the interim report but does not forward it to the Cabinet at this stage, excuse me, and that the report and draft recommendations be revisited in the summer when the work can be completed with more engagement with GPs. And is that seconded? Right, thank you. So,
I want a proper vote on that, please.
Yep.
And I want the vote recorded, Michael.
Just for a recorded vote, just need 4 members to indicate that that's what you want to do.
Yep. Right, so do members agree with that recommendation?
It's going to be a recorded vote. Yep. So just to be clear, if we vote positively, that put our hands up.
No, it will be recorded, so you'll be asked.
No, I know.
Yes.
I'm just because there's stripped me out on the planning committee one. There's double negative. I just want to be really clear. So if I vote positively, I'm saying that I want this report, as it currently is, to be continually worked on and improved. That's what I want to vote for.
It's not.
Well, that's
not what the recommendation is.
right. Then we'll add those words.
Not send it to Cabinet and keep working on it.
Yes, right. Then we'll add those words. I would like to propose the committee makes.
Just a minute. Either you're voting on the recommendations or you're making an alternative proposal. The recommendations are on the report. You've just read one of them out. So can we go ahead, please, and vote on that recommendation?
Can I just clarify? So obviously there are recommendations in the report, but it's open to any member to move a relevant proposal on this issue, separate to that.
Are you moving an amendment as the chair
No.
of the...
No, I'm moving this recommendation, which is the way that it should be.
It's not a recommendation, Councillor Wildey is moving. It's a proposal to do something. Yes, you have, but it's open. No, you haven't left it. If the proposal Councillor Wildey puts forward isn't agreed, then you can move on to do something different. Yes. Councillor Wildey is the first member to propose something concrete, essentially.
I would like to propose that the committee notes that the interim report, but does not forward it to the Cabinet at this stage, and that the report and draft recommendations be revisited, worked on, improved in the summer when the work can be completed with more engagement with GPs. Is that seconded?
I want more engagement with GPs.
Okay.
Okay, so just to be absolutely clear, so the proposal is to note the interim report, but not forward it to Cabinet, and to revisit and work on the report in the summer when there can be more engagement with GPs. The same task.
On a point of clarity, Chair, because I'm new, right? So, ish, I'm still a baby, all right? If it goes to Cabinet, does that mean that letter that's in the recommendations, that's basically right to central government on a report based on 3 GPs, does that automatically trigger that? If you...
Cabinet will be asked to.
Yeah, well, I don't want to ask them to do that this stage, so I want to do your option.
They can turn it down to Cabinet. They can read the rest of it and turn that one down.
I think it needs more work, I think it's much more.
There are several technical problems about this, aren't we? We don't know who would be on the new task group. As you said yourself, we don't know who's going to be here. We haven't said anything about officers' capacity to do this. Yes, I'm just reminding you that that is the consequence of the proposal that you've made.
That it's improved. Thank you.
Right, so can we have a vote on it then? It's a proposal.
Okay, Yes, I think everyone's clear what the proposal is. So I'll ask members to indicate whether they're for the proposal, against, or abstain. So Councillor Ahmed? Sorry. Councillor Barrett? Councillor Griffin? Councillor Lamas? Councillor MacDonald?
Against.
Councillor Murray?
Again.
Councillor Prenter? Councillor Price? Councillor Purdy? Councillor Thorne is left, of course. Councillor Turpin? Councillor Van Dijk? Councillor Wildey?
For.
So that's 1, 2, 3, 4, 5, 6. 1, 2, 3, 4, 5. So that's equal. So that's 6 members for and 6 against. So therefore, the chairman has a cast-in vote to determine the matter.
Would members accept we send the report but without the recommendations? No. Okay, then I'm for.
In that case, that's agreed.
Thank you.
More subjects on GPS this year now. When members say that they don't agree with this report, next time we have people like we have tonight and we talk about GPs, we'll remind them of that. Because your cabinet could have turned it down, Chair. It was a principle that all of your group worked really hard on this.
So that the principle is that it isn't shelved, which is...
Well, the principle is it's public now, Chair, so this can go out to everyone anyway.
Yeah, fine.
This goes out to our
won't
community.
say anything unique to Medway, which is what we need to answer. Is what's the issue with Medway? That's what
Right.
it's
Right, thank you, members. Sorry, members, thank you. That takes us on to the work programme. To you, Michael.
Okay. So just moving on to the work programme, I'll keep this brief. Yes, thank you. I'll keep it brief. So there are some proposed changes to the work programme, which I won't go over because I think it's fairly self-explanatory. There is this time, there's a Business Support Awareness Committee have recommended to the individual scrutiny committees to consider whether you want to have a look at the directorate risk summaries which sit beneath the corporate risk register. So that's a decision for the committee to make tonight.
Yes, I think that's a good idea. We discussed this at Business Support, and one of the issues is that the risk register goes to Business Support without coming through the specialist areas, and therefore it makes it difficult for people to make a decision.
Any other member? No? No, that's fine. I do have a view that should be reviewed after we've seen one or two of the reports. Thank you. Sorry, what was the other one?
Yes, so the two recommendations to agree are to approve the proposed work programme and to agree that the People Directed Risk Summary would come to the committee.
Yes. Yeah. Happy with that.
Is that agreed?
Yeah. Thank you, members, and good night.